Good morning, everyone, and welcome to the Alzheimer's Disease and Related Disorders Advisory Committee meeting. We're happy to have you here today with us. We can go to the next slide and just go over a few of the meeting logistics. As everyone's joining the room, just remember you can join by phone, by tablet or computer using the link, or you can join the audio by telephone only. The meeting ID is on the screen here. There is live captioning available right now. You can access this through Zoom. And we also have American Sign Language interpretation. Thank you, Byron, who is signing right now for our participants. And just a reminder that this meeting is being recorded. And so all the slides and the transcripts will be posted to the Cal HHS Alzheimer's Disease and Related Disorders webpage after the webinar is complete, within a couple of business days. And on to the next slide, just to make sure everyone knows that we're going to have public comment. So there is time that's reserved for that later on in the meeting agenda. And so attendees who are here joining from Zoom can use the Q&A function, which is located at the bottom of your screen, to ask a question, or you can just select the raise hand icon and it will show up on your screen. And then we'll call your name and unmute your line. If you're joining us by phone, you can press 9 on your dial pad to raise your hand, and then we can call out the last 4 digits of your phone number and unmute your line so that you can speak. So thanks again to everyone for being here today. And I want to turn it over to Catherine Blakemore, who is the committee chair and a family member representative.
Thank you so much. Good morning, everyone. It's great to see everyone that's joined or in the process of joining. As you can see from the agenda, we have a lot to cover today. So we're going to need to make our introductions and so forth pretty much shorter today. So just so we can get through that, and if we have time at the end, we can allow people a little more time to provide some additional information. I want to start by welcoming our new member, who is Sally Bergman. This is her first meeting. Sally is an attorney in California and fills our attorney position on the advisory committee. She has a lot of expertise in elder law, trust wills, estate planning. I'm particularly impressed and excited because she has some advanced law degrees in elder law. She has been certified by the Alzheimer's Association in dementia and end-of-life care, and has given generously of her time to serve on a lot of different boards and committees, including some national organizations, the National Academy of Elder Law Attorneys, including being the immediate past president of the Northern California chapter. So we're just excited to welcome you, Sally, and thank you so much for donating your time to this committee as well. I'm sure we'll benefit from your expertise. So with that, I want to just be able to go through a process of acknowledging which of the committee members are here, which is going to be there. I had to find my right piece of paper. So Derek Lamb, I believe, is here. Derek, you want to say good morning?
Thank you, Catherine. Derek Lamb, Vice Chair to this committee. Glad to be here today. Also want to mention that the state of California has created a long-term care facility access policy work group. They're going to have a kickoff meeting on February 8th, and I will be the designated representative from this committee to the group. We're also looking for an alternate. So anyone interested in being the alternate, please let me know. Thank you.
Thanks
and
so
also
much.
Welcome to Sally.
Perfect. Thanks so much, Derek. And the committee Derek referred to has been one of the longstanding priorities of this committee. So we're just very excited that CDA has taken that up and has a broad group of stakeholders that are going to really look at long-term care facilities, social isolation, the things that we've cared about. Meg Barron. Good morning.
I'm Meg Barron with the Alzheimer's Association. And I also want to say welcome, Sally.
Perfect. Wynn Canio.
Good morning, everyone. Wynn Canio. I'm a psychiatrist and geriatrician taking care of older adults in Marin and Sonoma County. Thank you.
Excellent. I think Dr. Farias couldn't join today unless I'm mistaken. Okay, I think that's right. Barbara McClendon, are you with us?
Hi.
There you are. Hi, good
Yes.
morning.
Good morning, Barbara McClendon. I'm the Public Policy Director with Alzheimer's Los Angeles.
Terrific, thank you. Dr. Mobley? Don't see Dr. Mobley yet. Pam Montana.
Hi, everybody. I'm Pam Montana, living with Alzheimer's and doing pretty well. Happy to be here with you all today.
And Pam was just featured in a news article, and I think Michelle is going to put a link to that in the website. So really interesting article about some of the new treatments and therapeutics that are available for dementia. So congratulations on that.
Yeah, thank you. Thank you.
Celine Regalia.
Good morning, Celine Regalia, Executive Director of Collaborative Care here in Napa, California.
Terrific. Andrea Roberts.
Good morning. My name is Andrea Robert. I live with mild cognitive impairment, and I'm very happy to be part of this committee.
Happy to have you always, Andrea. Todd Shetter.
Good morning, everybody. Todd Shetter. I'm the Chief Operating Officer for Active Care Living. We are a memory care provider of residential care in Southern California in both San Diego and Orange County.
Perfect. Julie Solier.
Morning, everybody. Julie Soulier, Assistant Secretary at Agency, helping to staff the committee along with several others. Nice to see you again, Sally. Welcome to the committee.
Doris Thompson.
Hi, everyone. I'm here, but my video's not working right today. But yeah, so I'm an emeritus professor of research at Stanford, and I'm here as a social science research representative. I've done research for the last probably 40 years now on caregiving, and have developed some interventions that have been useful and used in different programs across the country. So I'm very interested in promoting further interventions, particularly to promote the mental health of family caregivers.
Terrific. Thanks so much. And Sally, we just wanted to give you an opportunity to say good morning to your new team.
Good morning, everyone. I'm really excited to be here. And I can tell that I'm going to learn a lot from everyone here.
I think we all learn from each other, which is really terrific. I wanted to welcome Susan Damaris, who's the director of the California Department of Aging. So grateful that you could join us again. I don't know, is Kim McCoy-Wade here yet? Kim here? Yes?
Not at the moment, but she will be joining later.
She'll be here, so we'll welcome her when she comes. And then we're going to be, I'm going to put the minutes off for a little bit just to keep us kind of on time, because we have our first presentation, which is always of tremendous interest to the committee, which is our master plan for aging. And we have two of the phenomenal CDA staff, both of whom have done a lot of work in other areas, and I've had the pleasure of working with both of them. Sarah Steenhausen, who's the Deputy Director of Policy Research and Equity for CDA, and Renita Polk, who's the Assistant Director of the Office of Direct Care Workforce at the California Department of Aging. So grateful you could both join us and give us an update about the Master Plan for Aging. So many good things happening there. So I'm going to turn it over to the two of you.
Great. Well, thank you so much, Catherine. It's wonderful to be here with all of you, and always appreciate the opportunity to touch base. We could go to the next slide, please. So what we're going to talk about today is first, we'll be covering, I want to touch first on the state budget, but then also talk about our annual report that was released on the Master Plan for Aging, as well as the new initiatives we launched last week, a new Master Plan for Aging progress tracker. And then I'm just so pleased that Renita Polk is going to be here to talk about our direct care work initiative, which is just launching And then, of course, you can ask questions and discussion, welcome questions throughout as well. Next slide, please. So before I get into the details of our exciting launch of the new initiatives in the Master Plan for Aging and our progress report, I did want to just take a few moments to talk about the governor's proposed 2023-24 budget. We're really pleased because despite the administration facing a shortfall of $22 million, we are really pleased that the programs serving older adults, people with disabilities, and caregivers are, for the most extent, untouched. And the administration has really remained committed to doubling down in its efforts to advance the significant initiatives that received millions, hundreds of millions of dollars in funding over the past few years. So just wanted to start off with that. I can say for sure that we're really pleased that no programs serving caregivers or individuals with Alzheimer's have been cut at this time. So that's very exciting. So next slide, please. Thank you. So I'm going to talk about some of the highlights from our annual report that we release every year to touch on some of the significant advancements in the Master Plan for Aging. And this, again, is just the very high level highlights, and encourage you to look at all through the link available online that I can post in the chat. Under the area of affordable housing and investments, the governor and administration and the legislature have invested more than $20 billion in affordable housing. And we know that a lot of those resources will and do impact older adults and people with disabilities. Second is focusing on expanding capacity for housing and services to prevent homelessness. The Department of Social Services has launched their Community Care Expansion Program, which has invested over $100 million to fund 19 projects that create more residential care options for older adults and people with disabilities. Next slide, please. Under goal 2, focusing on reimagining our healthcare system to be focused more on a whole person approach to care across both home and community-based services, long-term services and supports, and healthcare. We're really pleased about the tremendous investments that have been made to expand healthcare affordability and access. We now see coverage for people in the Medi-Cal program who are 50 plus years old who are undocumented. We are going to eliminate the Medi-Cal asset test by 2024, which is really, really significant for the needs of our older adult population. Additionally, the working disabled premium, it has been eliminated in the Medi-Cal program. We saw a number of investments in our home and community-based services infrastructure. There were investments to restore the previous reductions to the in-home supportive services program. The last year's budget included $60 million for our adult day services programs and COVID recovery. And we're really excited that the Department of Rehabilitation is launching a community living fund, a $10 million project that's focused on preventing institutionalization and assisting individuals with their transition to the community. And of course, significant advancements in investing in Alzheimer's support. Of course, really, really pleased about the launch of the Dementia Care Aware, the nation's first screening and detection program that I know you all have been tracking as well. Next slide, please. In goal 3, area of ensuring inclusion and equity and not isolation, we've seen $10 million to expand volunteerism and intergenerational engagement through the Foster Grandparent and Senior Companion Program. Over $6 billion invested to bridge the digital divide. The Department of Aging has implemented the $50 million Access to Technology initiative to ensure that more older adults throughout the state can access the devices that they need to stay connected. We're really pleased with the expansion of our Aging and Disability Resource Connection program that is a key component to advancing a no wrong door system for older adults, people with disabilities, and caregivers. We now have representation of our ADRCs in 15 communities with 9 emerging. And we also received a very important grant from the Federal Administration and Community Living to develop a statewide no wrong door council, so that we have kind of a state leadership council that's focused on how we look across the system to ensure that people can access the services they need in a much more streamlined fashion. Finally, we are really pleased to be, if you could just go back one slide, in terms of protecting older adults and people with disabilities from abuse and neglect, really critical that the eligibility for the Adult Protective Services Program has been expanded from age 65 and over to now 60 and over, which is really critical. Next slide, please. Really a lot moving in terms of supporting our direct care workforce. This is both our family and friend unpaid caregiving workforce, as well as our paid direct care workforce. The In-Home Supportive Services Program and Department of Social Services has launched their Career Pathways Program, which has been a very successful way to engage IHSS workers in training and incentives. And you will hear more about this in just a moment, but Renita Polk has been leading our efforts to launch our California Grows Direct Care Workforce Initiative, which we're really excited about. And with all of these, it's tremendous opportunity to deliver targeted training to the direct care workers that serve older adults, people with disabilities, including individuals with Alzheimer's, as well as family caregivers. So look forward to hearing more about that from Renita in just a moment. Next slide, please. And finally, to wrap up our annual report highlights in the area of affording aging, Goal 5, really pleased that the Housing and Disability Advocacy Program has received nearly over $300 million investment, as well as the Home Safe program with $185 million. Both of these programs are really critical at assisting both people who are at risk of homelessness or those who are currently unhoused in securing the housing that they need and the access to services in the community. And finally, we saw increases last year of about 24% and this year of over 10% for the SSI SSP program. Next slide, please. So with all of that, that was our accomplishments from the last few years of the Master Plan for Aging. And in that same time, we have heard a lot from our stakeholders, including this advisory committee. All of our 6 stakeholder advisory committees have been critical to informing our understanding of the system and what we need to do to continue building out the Master Plan for Aging. So you may recall that in our September Day of Action, which was just a wonderful engagement, and about 1,000 people, both virtual and in person, where we heard from our stakeholder advisory committees, and they presented their key policy recommendations for the next iteration of the Master Plan for Aging. We took those recommendations and worked with our state partners, built from those recommendations to produce 95 new initiatives for the 2023-24 year of the Master Plan for Aging. I do want to note that it's not as if we have forgotten about the 132 initiatives from the last 2 years. Many of those initiatives have been built into these initiatives, and some of them have already, we've already done some of the work on them. And so they remain in the Master Plan for Aging, but for the first 2 years of our efforts. So we'll show you how you can get immediate updates on the status of both the 2021-22 initiatives, as well as the 23-24 initiatives by looking at our progress tracker. But right now, what I'm going to do is walk through very high level, what are some of the key initiatives that impact people living with Alzheimer's and caregivers. that are targeted towards this population, but also those that are inclusive of it. And I encourage you to look at the link that we're going to put up in the chat so that you can actually explore all of the different 95 new initiatives that we have in our 5 bold goals. Next slide, please. So I wanted to start out by just highlighting the key initiatives that respond to our goal 2 area of Alzheimer's and dementia, really in focus of this population. Initiative 43 calls on the state to improve access to the Alzheimer's Daycare Resource Center model. We want to take a lot of the lessons learned from the Cal Compass program that Michelle Johnston is leading and really hope to build from those lessons learned and expand access to those models in the community. The second initiative I want to highlight is initiative number 44, which is calling on the state to replicate best practices of the Healthy Brain Initiative and the Blue Zone efforts, which are so critical to preparing our local communities to respond to the needs of the population. Initiative 45, we know that the Dementia Care Aware program, the first in the nation, has been incredibly transformative. And we really want to continue to build off that work, improving dementia assessments and diagnostic process through this program, and particularly highlighting how that impacts people with Down syndrome. Of course, this was an issue that you all focused on at your last meeting. And we're really pleased that Department of Healthcare Services has really committed to continuing advancing this work. I also am really pleased to announce Initiative 75. You know, the meeting that you had, your last meeting, really calling out this issue of a better aligning systems across disability and aging, particularly as it relates to people who are aging with developmental disabilities and the need to have these systems understand each other. So this initiative focuses on creating a disability and aging community of practice to address the needs of older adults and people with disabilities, to do training, to identify best practices. And we did just apply for and receive a grant in partnership with the Department of Rehabilitation and under the leadership of the Department of Developmental Services. Our 3 departments are working together from a grant we received from the National Association of Councils on Developmental Disabilities to engage in a state level work group that will focus on kind of developing this community of practice. And we will participate with 15 other states in a kind of national level work group to share best practices and address these issues. So we're really excited about that. Next slide, please. So I wanted to outline some of the other key initiatives that don't target solely people with Alzheimer's or caregivers, but that are certainly inclusive of and touch on the needs of this population. First is housing. Our initiative number 2 is really focusing on looking at some of the rental subsidy programs that have been developed for older adults and people with disabilities. We've seen San Diego recently launch one, Santa Monica had one, and we want to learn from those local government models to inform our own consideration of how the state can think through these sorts of rental subsidy needs for older adults and people with disabilities, given the tremendous challenge of rental, the high cost of rent for impacting older adults and people with disabilities. The area of transportation, we're really excited to double down on our efforts here to support the expansion of integrated, accessible transportation models. This is something that our Disability and Aging Community Living Advisory Committee has really focused in on through the transportation work group and looking at ways to strengthen our consolidated transportation service agencies across the state. In the area of LTSS financing, we know certainly that this is an area that this committee has spoken up a lot about, and how to ensure that people who are in the missing middle or the forgotten middle, who don't yet qualify for Medi-Cal or other coverage of long-term services and supports, and how can we ensure that they don't have to expend all their resources to finance their LTSS needs. So we are really looking forward to continuing to evaluate the options for developing a universal long-term services and supports benefit. The Department of Aging will launch an initiative over the next very in the near future to look at financing and affordability of LTSS by building off of some of the work that's been done at the state level through the Department of Insurance's Long-Term Care Insurance Task Force, as well as other actuary analyses that have taken place. In the area of home and community-based services infrastructure, we know that many people across the state can't access the services they need, whether due to wait lists or just lack of availability of services. So developing our infrastructure is a really key component to ensuring that people can age with dignity and independence. The Department of Aging is very pleased to be working on a project that the Department of Healthcare Services is also launching. We kind of have a two-part home and community-based service multi-year roadmap where we're looking, DHCS is focusing on the Medi-Cal home and community-based services, and CDA is working on focusing on the non-Medi-Cal home and community-based services. We're working with a contractor, Mathematica, to do an analysis of the gaps in the service delivery system across the system of care. And then second, to build out a multi-year roadmap to actually build out the infrastructure at the state level so that wherever you live and whatever your needs are, you can access the needs, your home and community-based service needs. We just launched that effort on January 20th and happy to follow up with more information if you'd like. We also, the next area of older adult behavioral health, that is another area that this committee has been highly engaged in. We're really excited to be really doubling down on our efforts to expand access to behavioral health for older adults. And recently, the Department of Aging partnered with the Mental Health Services Oversight and Accountability Commission. We were thrilled that the commission approved $20 million to expand evidence-based behavioral health programs. So this just happened in the past, I think, 6 weeks or so. So we're working closely with the commission to partner with them on expanding access to two programs, one of which is called Pearls, and the other is called AgeWise. And we will be releasing the request, or sorry, the Mental Health Services Oversight and Accountability Commission will be releasing the RFA in the very near future. Another key component to system change is ensuring that people have streamlined access to services. And this is through the development of a kind of no wrong door system. Some people call it one door. It can be called whatever you want it, but it's a way to ensure that people do not have to have such a challenge in accessing the services that they need. So this initiative is focused on promoting the sustainability of our local network of aging and disability resource connections, and really a number of initiatives that we're outlining to expand access and develop a statewide no wrong door system. And then finally, last but not least, we're really excited about continuing to advance caregiver support and supporting our over 6 million unpaid family caregivers by developing a statewide caregiver equity roadmap and strategy. This is very much in line with the federal government's efforts right now through the RAISE Family Caregiver Act. And we're looking forward to developing a strategy so that we can ensure that our caregivers get the services and supports they need to take care of their loved ones in the home and the community. Next slide, please.
So Sarah, I just want to, Dr. Galley is here and he is slated to be on at 10:30. So if we could just take a pause and continue your presentation afterwards with the great information I'm sure Renita will share, that will be amazing too. So Dr. Galley, I want to welcome you to the advisory committee. It's terrific that you're able to spend some time with us. We so appreciate your vision for older adults and people with disabilities in California, really thinking about California for all, and all your work to promote a budget that allows so much of this good work to continue and be sustained even during kind of a more difficult budget period. So with that, I want to just say welcome, and we look forward to hearing from you. Thanks for joining.
Yeah, Catherine, so terrific to see you as always. The committee members should know that Catherine has been one of the most important people and advisors to me throughout this work. I met her in my first weeks in the administration when some people passed on, multiple people passed on her number and said, please go meet with Catherine, get her perspective, let her teach you some of the history of the movement and work and how I can glob on, jump on, and help support it. So Catherine, a lot of gratitude to you for your years of leadership, both formally at DRC and other places along the way, but really personally for all the support that you've given me on some challenging yet exciting opportunities that the administration and the state has taken on. So it's really a pleasure to have a moment to catch up with this group and share a few thoughts. I do want to also start off by thanking just this committee and the literally decades. I think you are the longest running advisory committee to Cal HHS and our department. And it's been a very meaningful partner. You don't have quarterly meetings for all of these years without shared recognition of the value, the iterative nature, the back and forth. And I hope you see the work that you do every single day through your leadership, through the committee work that happens, that it makes a difference for us. And I want to also just acknowledge Andrea, Robert, Pam Montana being sort of the voice of community, the voice of, you know, near and far, and making sure that we continue to elevate your work and your contributions to this. I always ask our team, how can we more deeply get close to that frontline voice? Where is my mom, for example, in the work that we do? And I think this committee, no surprise, because of the years it's kind of done its work. You've figured it out in a way that many others have yet to figure out. So let that be just sort of another feather in the cap of the work that you all are doing. My team shared with me the agenda, what you guys are up to today. I have to say my eyes always gravitate to this concept of how we use some of the opportunities from throughout the various departments in our agency and even beyond our agency to really amplify and catapult forward the work. So I have to say I'm really excited to hear what happens around community health workers, embedding that resource in some of this work, how we turn the quote paraprofessionals, the community professionals, as I like to call them, the people who know what's actually happening for individuals, families, and communities, into the workforce that we're missing to do this work more thoughtfully. So I see this as a really tremendous chance to elevate the connectedness of work that's happening in one part of the agency to the work that you all are considering here and now. Catherine, I also just want to acknowledge that the master plan for aging, the release of the recent update to the legislature that both celebrates the achievements that also reflect the work of the advisory committee. But more than that, it starts to move us down the road. Where do we go next? What's on tap for 23, 24? Where are we continuing to lean in? And despite what I would say is a uncertain, challenging budget compared to the last few, we're no strangers to this challenge. We've dealt with it and weathered the storm before. And I have to say, and I say this in a slightly quiet voice, the HHS family, we weren't messed with that much, actually. So much was continued. And that is not because of being forgotten. I think no matter where you are in the administration, no matter where you are in the legislature, the work that happens through the master plan, through what you all are doing, matters a lot. And that's why people didn't say, oh, let's give this program or this piece a haircut. And I knock on wood, I pinch myself, I try to talk about it quietly because, you know, there's still time for things to happen. But I'm really both proud and amazed of the ability this team has had to stand up and advocate and speak with both an intelligent and compassionate voice for what we continue to try to do. And that is in no small part because of the reliance on partners like you. I would just want to highlight a few really important milestones and achievements that I know you all have been a part of, and you can't talk to this group, especially when you look at where we are going to both support and garner the strength of older adults and Californians living with disabilities, including Alzheimer's, dementia, thinking about the expansion of health coverage that has been really in the works for a few years, and what we saw really take fold last year with individuals, undocumented Californians over the age of 50 getting access to full scope Medicaid coverage. This is an essential piece. We know that coverage is not sufficient, but it is a start. And this has been an important piece. And I'm proud of being in an administration that sort of protected this cause, like we're going to protect the whole notion of healthcare for all to include all Californians, no matter their documentation status, by early 24 to receive that coverage. But this is an important milestone, and one that I don't think happens without the advocacy of groups like this one. Additionally, the Department of Healthcare Services, in some ways anchored in CalAIM, anchored in the Office of Medicare Innovation and Integration, looking to do more for individuals who are, quote, duals, Medicare, Medicaid eligible. How do we really push the envelope forward with new programs? I often say it's a shame the state doesn't have a bigger role in the Medicare program, because I think some of the social supports and things that we do to look at social drivers of health really should be not just glommed on in a Medicaid sense, but really for the Medicare program. So I'm really hopeful about the work that that office will continue to do, and then the work that DHCS through the Medicaid program is doing on duals, and within CalAIM, some of the important supports, community supports that were passed or approved as part of the CalAIM program, 14 community supports that include sort of respite support services that I think will touch strongly those who are eligible for the Medicaid program. The workforce training work, I think there's, I started talking about CHWs. That's going to be an incredible opportunity that only is fully realized if we have sufficient investment in the training programs. This is one area that honestly, not that I wake up every day, but I wonder every week if it's going to take a little bit more of a haircut than it already has, if we're going to be delaying some of these efforts more than I know I wish they would be delayed. But know that we, across our agency, across the various different departments, including the work that Susan's leading at CDA, are on top of workforce opportunities, looking to drive, as I like to say, a truck through these opportunities. Let's see how much we can actually get done and do on workforce. And the recent awards by HCI for everything from behavioral health to certified nursing assistants, the work on caregiver supports, all of this, I think, builds into hopefully creating not just in number, but in skill and talent, the workforce that we know we need to address some of the challenges that we're talking through. I'm going to wrap up there. There's a lot of other investments that are worthy of highlighting, but I do, Catherine, if it's in the cards, because I don't really get this opportunity often, and get tired of hearing my own self ramble and talk, would love to spend 5 to 10 minutes just engaging on a few questions and critiques, like, hey, I wish you were doing more of this and less of that. I know Susan gets it often, other directors and departments hear about it as well, but I always enjoy the opportunity to hear clearly from all of you what you wish we were doing differently. And if you want to give us a thumbs up on something that is happening already, I'm always willing to take those acknowledgements as well. But Catherine, if it's in the cards on the agenda, would love to engage on that a bit too.
We'd love the opportunity, and I'll just say we just had begun hearing about the new community of practice, which I think advances sort of the HHS objectives of integrating the work of various departments, and to have different departments thinking about coordinated strategies for aging is really significant. So thanks to you and your team for your work on that. And I noticed that Derek Lamb has his hand up, so he has something to say too, I think.
Thank you, Catherine, and thank you so much, Dr. Galley, for your leadership and also your team working together to enhance the lives of many people within the umbrella of your department. So a couple of days ago, President Biden announced that he's going to end the national emergency on the COVID-19. So what is the impact on your department in terms of the people you're serving?
Yeah, really tremendous question. I think a couple of things to say, Derek. And first, it's good to see you and really encouraged to know your continued involvement in this group and the work that you have done for so long for so many Californians. So just want to acknowledge that. In relation to your question, first, California has been preparing for this moment for a long, long time. I think other states have as well. And we have done, I sort of think about the category of three areas. There are things that California gained as a result of the public health emergency along the way that we have both fortified and made permanent. So some of the telehealth options that really flipped on a dime, especially in the healthcare space early in the pandemic, California's agreed to keep those going as it relates to things we pay for, and encouraging the Department of Managed Healthcare and other providers through legislation, other health plan providers through legislation, to keep that work going too, and paying for those visits at the same level that you would pay for in face-to-face. And I think this is a key piece of unlocking the potential of our workforce and making sure that access isn't just lip service, but older Californians who can't easily get to every single appointment. And imagine that they had 12 a year in normal times. Now they might get 6 in person and 8 virtual visits because they can be supported and their provider can keep the lights on and stay open because we are reimbursed for it. So there's the category of things like telehealth that we are going to continue to support, and I think fortified even more than the feds did. Then there are some things that will change, but because of legislation like SB 510, which protected testing, vaccinations, and therapeutics at full coverage in and out of network for 6 months after May 11th. And then after that 6 months in network without cost sharing for Californians, moving forward, allows Californians to feel secure that they're, what I'm going to say, COVID hygiene, right? Vaccines, testing, and treatment are going to be within reach, no matter what happens sort of within the federal context. And then there are things that really impact the safety net. So there's going to be some real losses, right? California, when I look at our achievements in like programs like CalFresh, where we've been able to, through some additional aid, emergency aid and grants, been able to really buttress and strengthen the amount of support we're giving low-income individuals and families in California. Some of that is going to go away. And so we are going to be faced with not just some hard decisions, but the need to rally around people that are expecting and have become accustomed to a level of support, and frankly, maybe thriving because of it, and having to backfill there. So I don't want to make it sound like California's squeaky clean through all of this. There's going to be some challenges, but I think because of decisions that people have helped the legislature and the administration make, we're better off than some other states. Derek, you just got the first explanation of this. Honestly, there's been a lot of press interest and you may actually, Derek, know even more than the governor knows at the moment on this issue, because he's been asking me as well.
Thank you so much, Dr. Galley.
Yeah. I see Andrea's hand up, Catherine. I don't know if it's okay to go to her. Yeah, let's do it.
Just real quick, thank you, Dr. Gelly. I'm actually benefiting from a lot of these services. In-home supportive services. I was gonna have you guys meet my worker. She's actually doing some laundry for me. But I am actually benefiting from a lot of these services, in-home supportive services, affordable housing, Medi-Medi. And it's so nice to hear that these programs are not being eliminated, but they're being expanded. I was really impressed with, I think it was 2021 when they expanded Medicare. I was in Virginia at the time. So that means people like myself that was under 65 was able to benefit from Medicare. And then also in real time, again, I'm benefiting from these services. The workforce group, my in-home supportive services worker is happy, makes me happy. All these services I always share with myself. I advocate for myself all the time, and I also share it with my peers. There's a lot of people that don't realize that Medi-Cal currently have the access of 130,000 a year. People are under the old impression that you can only have like $2,000 in the bank. So I'm constantly trying to remind people and update people of some of the newer policies in regards to Medicaid so that they can apply. So again, thank you guys so much. You know, Sarah, I really enjoyed your presentation. But again, as a person that's on this committee, I am benefiting from a lot of these services, and it's very helpful, and it helps me to have less stress. Thank you.
No, not a question, but a comment, Andrea. Thank you so much. It's good to hear. Moving from the east to the west has been hopefully a feeling of upgrade in terms of the services and the support, and what Sarah and Susan and so many others are promoting. I think the asset limit and the asset test functions and what has changed there, I think they sneak by a lot of people. So I'm really grateful you brought it up. They did not come at a small price of advocacy for years, I would even say decades. And to see those things get transformed and changed, I think is a huge deal. And I guess one comment, and Catherine, not to again screw up the meeting agenda, but I would love to hear more, not right this moment, but at the end of this meeting, blow the playbook open on community health workers, right? Andrea is talking about IHSS, but there's this new game in town of how do we use people, professionals in the community. I'm not talking about, you know, certified professionals, but people who know the communities, know the families, know what's around the block, and how do we use them to really support Andrea, yourself, and others who may just need a little bit more support. This is a tremendous chance to really bring another workforce to bear in California. And my dream is a decade from now, or 5 years from now, we look back and say, how did we ever do without this? Like, how did we ever figure out how to support one another without knowing that there's individuals who are doing some of this work anyhow, but now can be supported and frankly paid for the work through some of the investments at the state and federal level. So I hope that your collective creativity will give us new ways of thinking about this resource as it relates to the work you guys are concerned about.
Well, we look forward to reporting on that to you. We have a little discussion at the end of things we might want to tell you. So that'll be a great opportunity. Thanks for framing a good question for us. Does anyone else have a comment or a question for Dr. Galley? Okay, thank you again for joining us. I always say I'm so proud to be a Californian because of the advances we've made. We are really in such a different place, and a lot of that goes to your leadership. So thank you.
Well, it's a privilege, and I just end by thanking you, and Susan, you in particular deserve constant shout out for the leadership you bring and the team you have assembled to keep doing this work. So in partnership. Have a good rest of your meeting, and thanks again.
Thanks so much.
Thanks, Secretary.
Well, that was a terrific opportunity both to hear and be able to ask some questions, and really good questions that people on the committee asked. So thanks for doing that. And Sarah, I'm not sure whether you were done and we're ready to go to Renita.
Yeah.
Is that about
I
where we're
am like 20 seconds. We'll be really quick. I want Renita to cover the workforce initiative, if that's okay. If we could just pull up the slides. It was wonderful to hear from Secretary Galley. I'm very aware of the time constraints you all have here, so we'll be quick. I just wanted,
and then we're going to move into Lauren right after that.
right, exactly. Thank you so much. I just wanted to note that we have this implementation tracker that's available online that you can look up each initiative and its status. So I definitely encourage you to utilize that, and we'll put the link up. And at this point, we can go to the next slide, and I'm just really pleased. Again, this just talks about our data dashboard for aging. We also, one last thing, have a aging and disability planning grant program that we're about to launch for local planning at the community level. So we encourage you all to look for that opportunity in our announcements. Next slide, please. So now it's my pleasure to turn it over to Renita Polk to talk about the California Grows Workforce Program. Thank you.
Good morning, everyone. Thank you, Sarah. And thank you, the committee, for having me. I'm going to provide a pretty high-level overview of our Cal Grows program, which is our direct care workforce training program that we are just launching at CDA. Next slide, please. So Sarah already discussed the 5 goals in the master plan for aging, so I won't say much more about that. Just point out that the Cal Grows program, it fits into that goal for caregiving networks and providing support for caregivers. Next slide. So this slide here, what I really wanted to get at with this slide is a discussion of the goals of our Cal Grows program and how we're going to accomplish those goals. So the program is funded through the American Rescue Plan Act. And so the state received $150 million to implement a training and stipend program, which is now Cal Grows. And the goals of the program is that first highlighted phrase there, to improve quality of care and to help keep older adults and folks with disabilities in their homes and out of institutions when it's not needed, and to respond to shortages within the workforce. So those are the goals. So even though this is a training program for direct care workers, ultimately the goal is to improve the quality of care for those that are receiving care, recipients of care. And how we're going to do that with this program is to help provide consistent care by retaining direct care workers, and by training direct care workers, helping to improve their skills, and by retaining workers, then we'll maintain consistent care for those folks that need it. Next slide, please. So the Cal Grows program, there are a couple different pieces that I will talk about pretty quickly. So the 5 training pathways, this is also known as the IHSS Career Pathways Program. But we are leveraging that program at the Department of Social Services, which Sarah also touched on this program briefly in her Master Plan for Aging update. But workers that are participants in the Cal Grows program also have the opportunity to take the courses that are being offered by the Department of Social Services. The Learning and Innovations Institute. So CDA is building a database that will have different training opportunities. You can kind of think of it as an inventory for training courses. And this will be a small part of the larger Learning and Innovations Institute. And we are working with UCSF to conduct an evaluation of the Cal Grows program. And then the last piece on the slide here is the CalGrow's Innovation Fund, which is the largest part of this program. And I'll talk about that a little bit on the next slide. So the Innovation Fund, it's a pot of funding that will fund grants for innovative approaches to training and incentives for direct care workers. These funds will be going to employers, training providers, a wide variety of different types of organizations. So we actually just notified successful applicants a few days ago on January 31st. And the plan is to have all of these programs launching no later than March 1st. Next slide, please. And so I did mention on the previous slide, but what the funding will be used for, a variety of things, but really what we want to focus on is addressing accessibility for training. So helping direct care workers get access to training and helping them address any barriers that they encounter while trying to access training. But for the Innovation Fund, so we received about 143 applications, which was over $150 million was requested. And I apologize, there is an error in this slide. It actually should be 89 million that was awarded. So not the 82.6 on this slide, but $89 million that will be awarded to 78 different applicants. And since I know this is the Alzheimer's and dementia related committee, I wanted to point out the focus on training workers to work with folks that have Alzheimer's or other types of related dementia. So there's 24 million total in the Innovation Fund that will focus on training relating to Alzheimer's and dementia, which is for 19 applicants. So I know we are running low on time, so I will stop there and pass it back to Catherine, I believe.
Terrific. And I think what we're going to do is have Lauren present, and I'm hoping Renita, Sarah, and Lauren can all stay and answer any questions at the end of kind of that combined presentation, if that works for all of you. So Lauren, take it away.
Fantastic. Thank you, Catherine. And I should be fairly quick and don't need the entire 20 minutes that was originally provided. So hopefully we'll help with time a little bit moving forward. So I am just going to present on a few of the key initiatives that the Department of Public Health is working on towards the Master Plan on Aging. And some of those you heard from Sarah earlier as well. So next slide. So for our team here at the Department of Public Health, one of the big initiatives that is in the current Master Plan on Aging and a future initiative is to promote the Blue Zones for dementia-friendly communities. And we are happy to say that we have started progress on this. We have a pilot project with Sacramento County on a Blue Zone project, and that work will continue, and ideally with a pilot project, we'll learn some successes and be able to continue really implementing this and promoting it in a larger fashion in the future as well. So that's our first initiative. Next slide. We also have an initiative. Oh, I'm sorry. If someone could move the slide one more, that would be great. Oh, perfect. Thank you. We also have an initiative to share public health messaging, education, culturally competent, equity targeted approaches. And we've been fortunate at the Department of Public Health to do this in a couple different ways. We have developed an Alzheimer's awareness social media toolkit that other projects are able to use, and it gets updated about 4 or 5 times a year with varying different messages and images for everyone to utilize. It also gets posted on the CDPH social media platforms as well. And then also this kind of culturally competent, equity targeted approach for awareness and education is embedded in the Healthy Brain Initiative as well. And so all 6 counties that are currently working on the Healthy Brain Initiative continue to communicate as well in their communities through public awareness and community engagement strategies. And then an additional piece is that we're really excited to announce, and I know we announced at our last meeting, but we'll just say again that we're going to have our first public awareness campaign focused on educating the public on the signs and symptoms of the Alzheimer's disease and related dementia. And so we're really excited. Runyon Saltzman starts with us here shortly. We're finalizing our contract and we'll be able to have that campaign ongoing over the next year or so. Next slide. Another initiative is really to build in our older adult focus to existing suicide prevention programs. And luckily here at the Department of Public Health, we do have a CDC funded comprehensive suicide prevention program. And they do focus those strategies on the impact of older adults. So this is an area, where we've been able to really increase our messaging around older adults and existing suicide prevention programs, and really increase our messaging, our education materials, all of those various components as well. Next slide. Oh, and I do want to say overarchingly before we go into this particular one, something that's really important is the initiatives that you're seeing here. They were all part of the prior master plan aging initiatives, and in the coming year, they're going to continue on. So we feel really fortunate to continue to work towards these initiatives and build on what successes we've had already, and then also continue to see bigger impact and outcome over the next year as well. And as we've heard from everyone this morning, we've been very fortunate in the Alzheimer's work here at the Department of Public Health that we have not received any budget reductions in the work that we're doing. So we're able to continue all of these programs at this time. So really excited that that has happened moving forward. So this initiative that we have here is really to continue California's commitment to target clinical research. And so this particular piece, we were able in the last year in 2022 to award 7 new research grantees, and that's at $8.7 million. And so that work will continue. Those are 2-year research programs. And then we plan to continue to fund additional research after that as well. Something we're doing that's a little different than what we've done in the past is we plan to have a symposium series with our researchers so that others can learn more about the research that we're funding, both the impact and successes of the programs that the research that we have funded in the past, as well as the research we're currently funding. So more to come on that. And I look forward to sharing with you all when we have that, set up and available for everyone. Next slide. We also are working on developing a plan for equity-focused dementia prevention public health campaigns. And so with this, we're really excited to continue our Healthy Brain initiative. And so with that, we're going to continue to fund the 6 pilot counties that were part of the program. And just yesterday, we released our Healthy Brain Initiative RFA to include 6 or more new counties. And so we're really excited to bring on more counties into that initiative. It's really focused on prevention in the local community level and making brain health and Alzheimer's and related dementia part of the conversation within local health departments. So that initiative will continue and is ongoing as well. And we'll have 2 to 3 more years, depending on which project we're talking about, to continue that work at the local level. Next slide. We also at the Department of Public Health have an initiative to continue to expand transparency on state data on nursing homes, and that includes quality, staffing, financing, and both during COVID-19 and ongoing. And our home and community-based service spending plan includes resources to develop this long-term services and support data dashboard to really be able to provide that transparency and that data moving forward. Next slide. Another one of our initiatives here at the department is to continue to expand culturally and linguistically competent communications for older adults and people with disabilities and their families. And so I'm excited to say this has continued as well. And in the 21-22 state budget, we invested 10 million in ongoing general funds for language access and cultural competency. And this includes for older adults, those with disabilities and family members. And so this is a really big campaign that we're lucky to move forward and continue in the coming year as well. And last slide. Another item that we do have in our portfolio for CDPH and is in the coming year is to review the roles of licensing, long-term care, ombudsman, and adult protective services and their experiences to other states to prevent and address abuse and neglect in long-term care facilities. And I'm really excited to say that the Interagency California Elder and Disability Justice Coordinating Council is going to prioritize this initiative in the coming year. So we've got quite a few initiatives here at the Department of Public Health that intersect with the Master Plan on Aging. And we're really excited that we've been able to see some success this last year and really continue to build on that in the coming year as well. And just want to really say how great it is to partner with the Department of Aging. We have a lot of conversations and we continue to move this work together as a team. And even though there may be different departments assigned to different initiatives, it's really teamwork that comes together by all of us partnering and having those continued conversations. So that's just a quick overview of where we're at the Department of Public Health. But Catherine, I think we're going to turn it over for questions.
We are. Thanks so much, Lauren. That was really informative. A lot of good information. So really appreciate you taking time to join us today. So we have first opportunity for members of the committee to ask questions of any of our three presenters. And I see Barbara's hand raised. So go ahead, Barbara.
Thanks, Catherine. So two are ideas for future discussion or presentations at future meetings that I just came to me as presentations were being made. One of them is about the ADRCs. I would love to have someone come to this committee and really lay out the vision for that, where we're at with this. And I think we need to have some conversations. This was prompted in another meeting I was in earlier in the week about how is California going to ensure that these ADRCs have all of the information at hand about the full array of services. So the conversation I was in, people started asking, well, if it's a list, will it address the quality of these services? And so I just think there's a lot of questions around, how can we ensure that this no wrong door that we want everyone to walk through is really going to give people access to good information about including the quality of these services, the full array of services from what you get in the home and communities all the way up to what someone might want in an assisted living or long-term care. And it may be interesting to ask someone from Wisconsin to come in and do a little presentation for us because they've done some really interesting things with their ADRCs when it comes to dementia. So embedding dementia specialists in their ADRCs, they've done it statewide now. So that might be kind of interesting for us to think about a direction maybe we could urge the state to move going forward. Secondly, Lauren, this is you. You were talking about the grant made to Sacramento. As that gets further out and they've got something to talk about, it'd be very cool to have them come and say, what are they doing to make Sacramento County more dementia friendly? Because maybe we can get ideas that we can then take back into our local communities or counties to try and see if maybe we can jumpstart some things. And then the last, Sarah, for you is, and I know you had to go quickly because our time is short. There's so much information. But is there anything more you can say about the 4.5 million that is going out to communities for dementia friendly work?
Oh, okay. Thank you for that. So 2 questions. One, I did want to point out great questions and point on the ADRC issue. We've done, I think it could be a great agenda item. We've done work with a wonderful consultancy called Collaborative Consulting that has helped lead our work in kind of an analysis of our ADRC program and looking at other states and doing index stakeholder interviews. So anyways, I think there's a lot to talk about, highlighting the issues you've discussed. And in regard to the 4.5 million investment that I had to run through really quickly at the end, sorry about that, for age and disability planning at the local level, which includes Alzheimer's. So I do think that we're inclusive of all, we need to be aware of and inclusive of all that. The RFA will be being released hopefully in the next few weeks. So as long as you are on our web, email distribution list, you will get information on that. I can also send you the contact information for our leads on that.
Great, thank you so much.
Okay.
Thank you for the suggestions about presentations. It's one of the things that we really appreciate. I really appreciate about the committee is lots of good ideas and sort of committee things that are important to the committee to learn about and become informed about and ask questions about. So I'm sure Michelle, who's always taking amazing notes, will add that to the list of things that we can do in the future. Does anyone else on the committee have a question? And I did want to just, in case you didn't see Dr. Mobley, he's here and with us. So thank you so much for making time to join us. I had one question about workforce. I really appreciate the sort of integration of how individuals beyond IHSS workers can access training opportunities. And I'm interested in sort of what's the communication strategies so workers know about that opportunity, and are they then eligible for the same sort of stipends and other career advancement opportunities? So if someone like
Yeah, I can answer that question. Renita had to go into another meeting.
Perfect.
So
No problem. Thank you.
If I heard your question correctly, it's how, for the part of our program that is leveraging the IHSS Career Pathways program, how are we going to ensure that the non-IHSS direct care workforce can access those training opportunities? Great question. And the incentives, because they also get the incentives that go with it. So we are working with a third-party administrator that we were referred to and connected to by Department of Social Services. They're called CELED. And in that capacity, they're administering our Innovation Fund program, but they're also serving as, they have a coaching service that they provide to the direct care workers. They're doing that for IHSS Career Pathways, and they're doing it for our non-IHSS direct care workforce. So we have a number of strategies for outreach to the direct care workforce population, reaching out into the communities to ensure that those populations know about the opportunities available in that. We will be launching that effort, I think, within the next month. So it's a really important question. I think we're going to learn a lot because we don't have a natural pathway like IHSS does, right? It's many different, they're in many different settings and programs and all of that. So we will keep you updated, but happy to answer any questions about that.
That's great. I think, 6 months from now, sort of hearing how it went and what the participation
Lots
level
of lessons learned, I'm sure. Yes.
Yeah, would be great. Workforce is so important to making systems work well and people getting the care they need. So
absolutely
really appreciate the energy you're investing in providing those training opportunities. Do other committee members have any questions? So if there aren't any, my understanding is we were also going to have an opportunity for public comment is that correct, Sarah? Is that not Sarah, Michelle?
Yes, we can. If you don't have further questions from the committee, we can open.
It does not look like we do at the moment. So I thought we could open it up and see if anybody else had any questions. And while she's kind of coordinating the public comment period, I'll just note lots of people have been adding items and links in the chat. So if you're like me and you have a hard time like focusing on all the good information verbally and in the chat, just know that there's lots of good information that Susan and others have posted in the chat that you might be interested in.
There is one hand raised in the attendees for Janet Van Zoren.
Terrific.
Janet, I've unmuted your line, so you just press unmute as well, and you can go ahead and ask your question.
Hello, I'm happy to see everybody here today, and I just have a few comments. First, I want to thank you for the wonderful opportunity for presentations that you had last month. Really appreciated that. And secondly, I just want to say how happy I am to hear that on some of the initiatives, the Down syndrome community and people with IDD were mentioned as being included in initiatives that are on the table now. And I'm really excited to see that. And thirdly, with regard to the ADRCs, I'm wondering whether or not there's going to be an interest in bringing them up to a point where they have the expertise with which to diagnose dementia in people who have pre-existing cognitive impairments, and also whether or not the ADRCs will be well voiced on what resources are available to those populations. Again, thank you for all the work that you guys are doing. I really appreciate it.
Thanks, Janet, for always joining and asking good questions.
Thank you.
Was there any other public comment?
So if I,
oh yeah, Dr. Mobley, please go ahead.
Thanks. I think thanks to Janet for that. You know, I think this committee can have a very positive role for the ADRCs in California. There's only one ADRC that has committed in a very powerful way to folks with Down syndrome, and that's the UC Irvine ADRC. It's been in operation for many, many years under Ira Lott's guidance, and they've done an outstanding job. At UCSD, we now are increasingly focused on that population, and I'm happy for that. But I think that I know that this is not the case more generally in the state, and I could imagine this committee becoming very active in promoting programs and awareness, and really even training around the care of elderly people with Down syndrome and intellectual disabilities at the ADRCs across the state. I think it would be a great service to them. And I think it would be a wonderful thing for those ADRCs to be much more aware of this population. In California, a rough estimate is that there would be about 11,000 people with Down syndrome, for example, just for Down syndrome, that would benefit by access to ADRCs. And in fact, ADRCs would benefit by caring for them, but also, allowing them to take part in clinical trials and in other activities, research activities. So I think this committee could have a very pro-social role in that regard.
Okay,
Kathy, could I jump in and clarify something for Dr. Mobley too?
Please.
Okay, so thank you, Dr. Mobley. I think we're in our acronym alphabet soup a little bit. Because you raise a very important point about the diagnosis and assessment of individuals with cognitive impairment through the Alzheimer's disease centers. When we talk about the ADRCs, it's the Aging and Disability Resource Connections, which are a kind of clearinghouse of information. However, to Janet's point, very important point about how we ensure that people who go to the ADRCs, whether they're family members or individuals with developmental disabilities or caregivers or what have you, that they get connected to the services at the Alzheimer's Disease Center programs that they need. And that there is this awareness of the programs across the system that serve the population. So it's a really important point. So I just wanted to clarify the acronyms there. But
thanks for doing that. And I think one of the opportunities I see is in this new community of practice that's cross-agency, is to have a discussion about sort of how that information sharing works better, right? There's a regional center system that provides services to people with IDD. How do we make sure that the ADRCs, the community resource, knows about that, and the other research centers, right? So I think I just think this is such a nice way to begin to think of a more integrated aging system than just one entity or the other. So really look forward to hearing more about that. And Derek, you had a question, which I think will be our last one, because we want to then move on to the community health worker presentation.
I actually comment. Thank you, Sarah, for making that clarification. I was about to jump
Okay,
to that too.
perfect. I think
But
many
in
of
the
us were.
meantime, I
Yeah.
would like to propose that this committee expands the scope by not only looking at dementia, but also brain health in general. I think it's interconnected in many ways. And I do think that younger adults who might have propensity to develop dementia might benefit from an early, brain scan, if you will. And I think this is also personal to me after what my family has just gone through with a younger daughter. But I do think that, this is something which the state, they want to look at seriously. So thank you. We can talk about that.
Perfect. Thanks so much, Derek, for that. So I think we are ready to move on to our next presentation. And we are going to be talking about a subject that Dr. Galley was particularly interested in hearing our input on, which is community health workers and promotores. And we're really fortunate to have two very experienced individuals present to us about the work that's currently going on. It's James Regan, who's the Assistant Deputy Director of the Health Workforce Development at the Department of Healthcare Access and Information. And he previously has worked in other capacities, working on promoting health and getting that information to diverse communities in the Central Valley. And Maria Lemus, who is the founding executive director of Visión y Compromiso. She's been in that position since 2000 and is also a founding member of a national association that looks at ways to best utilize and strengthen community health workers. So with that, it's really my pleasure to turn it over to James and Maria and hear the good work that's happening. And I know they're also available at the end to answer some questions for us. So thank you, James and Maria. I'm not sure which one of you is going first, so let you take it away. And I think we need the next slide. There we go. Perfect.
Nice. Looks like maybe I'm going first. So thank you so much for the introduction, for having me here today. Very, very excited to share a little bit of the progress around the Department of Healthcare Access and Information, otherwise known as HCI, and what we're doing to promote and grow the community health worker promotore workforce. And so a little bit of background, and then we can get into maybe how it relates and interconnects with this group. So there was a state plan amendment and Medi-Cal benefit implemented in California for CHWP services, which is amazing. Department of Healthcare Services put in a ton of work on that, became active this past July. And so HCI's portion now is to build on that and carry the work forward by developing a state certificate program to allow CHWP workforce to bill through Medi-Cal. And right now where we are is in the process of outlining the core competencies and training programs and specializations for this workforce that has been providing care and crucial services in communities across the state for a long time. But we're taking sort of the next step and formalizing some of the training programs, including specializations such as Alzheimer's, to be able to provide that very specialized coordination of care that exists for the Alzheimer's community. And so on the next slide, I think is a little bit more information about our goals. What we're trying to achieve through this is ultimately to increase this workforce across California with a little bit of a lofty number target there of an additional, certified 15,000 by 2028. But what's crucial right now is that over the course of development of this certificate process and the training programs in particular around the specialties that may exist, is that we want to engage all of you and many, many others over the course of the next few months through a pretty extensive stakeholder engagement process to develop and launch this certificate and training, and also then explore future grant opportunities for these training programs and other potential recipients of this workforce. And so then on the next slide, I know we're a little bit short on time, so I'm going quicker than I think I normally would, but there'll be plenty of
We're
time.
actually caught up, so use
Are
the
we caught
time
up?
that you
Okay.
want. Yeah.
I appreciate it. So a little bit of an overview, because stakeholder engagement can mean a lot of things. We have this 2-phase process that we're going through right now. Actually, we just wrapped up the first one, was really background research and a little bit of analysis, sort of a landscape analysis on the current state of the CHWP workforce in California. So we did a lot of sort of key interviews, including with community-based organizations, existing CHWP workforce, tribal organizations, et cetera, who could help HCI get a better grasp on the current state of this workforce in California and where to start as far as a training model to then present in phase 2. And so phase 2 just started this week. We're doing a series over the next few months with in-person feedback sessions, online feedback sessions, and then informational webinars where we, HCI, are taking all of your feedback and then presenting it back to ensure that it was incorporated correctly with understanding and sort of to show you the progress of your work as stakeholders in this effort. And so I really appreciate the opportunity to present to you today for just being able to share about the work, but also to share the opportunity to get involved if you'd like to, and provide your feedback on, in particular, the training program at large, but in particular, the potential for an Alzheimer's specialty. So if you are interested in getting involved, there's an email address right here, chw@hci.ca.gov. And then there's also a link here in the slides that are posted in case you want a little more information first. HCI has a ton of information posted on what's going on with this effort. And then I think I have one more slide here before I pass it along to Maria. I'm not going to go through this line by line, but this does include more information on what is included in stakeholder engagement and ways you can get involved. We're doing half-day in-person regional meetings. We're accommodating multiple languages. We want feedback, very specific feedback on needs and training areas. And then there will be sort of an iterative process between virtual group sessions, which is, I think, a fancy way of saying just sessions where we get your feedback, and taking more of a deep dive on specific areas within the certificate process, within specialty development, and within training program, sort of design that we would then take back and incorporate into the model and then present back in virtual information sessions to show progress and how the model is changing based on your feedback and other things. In the end, the product that we want to have sort of built together is a high-level set of core competencies to incorporate into CHWP training programs, including specialty programs like for Alzheimer's, and also the requirements for an individual to become certified as a CHWP in California. So I think that's really what I had as a very high-level overview. Once again, I appreciate your time, and I'm really excited about this. So with that, I know there's going to be, I think, a joint Q&A at the end, but I'm happy to pass it along to Maria.
That's perfect. Thank you. Welcome, Maria. We're so grateful for you joining us today.
Thank you very much, Catherine, and thank you, Jared, for that overview. I'm really excited and pleased to be here today. I think that the more we're able to articulate our framework as Visión y Compromiso, I totally appreciate it. And Alzheimer's is an area that's aging and Alzheimer's are particularly important to us, as the numbers of Latinos who are experiencing dementia and Alzheimer's is increasing. And as an older adult, I have particular interest in this, of course, as we'd like to see what is in store for us in the future. And I'm glad to be here. So I'm going to start with just a little overview of Visión y Compromiso. We're into our 23rd year of Visión y Compromiso and our network of promotoras and community health workers across California. And we started with women coming together, and we're called the Network of Promotoras because we're primarily women. And we started with the idea that we wanted to share information. 20 some years ago, promotoras were primarily volunteers, and many of them are still today. And there really wasn't a large community health worker component. I came from the world of HIV/AIDS, and we had CHOWs, and we had a few community workers, but really there wasn't an institutional space for community health workers until probably, I'd say 15 years, 18 years, when universities started really doing research regarding chronic disease, diabetes, hypertension, and the model became a little more popular and certainly was integrated through APHA and some other venues. But when you look at who are promotores, this will give you an idea. No, I'll go back to the first slide. So we are younger, we're older, we're mostly women, we're indigenous, we're Afro-Latino. We come from many countries, Latin American countries, native born in the US. When you think about the Latino community in the US, we're about 62 million. In California, we're almost majority. And you think about the diversity of who we are and what kinds of plans and solutions are being offered to us when we're so diverse. You try to develop a plan for a Mixteco community that doesn't relate to the third generation English-speaking Latino. We're just so diverse. And I think this picture shows how when we look at plans and options and solutions and recommendations for at least the Latino community, we have to look at it with an eye of diversity of who we are, where we come from, what language do we speak, and what culture do we have in order to relate to the essence of who we are. The next slide, please. This is our model of change. We believe that if we support the promotor with information, education, training, leadership, they personally will change. They will change their families and they will change their community. And that's what we've seen over the last 20 years. We started providing, the promotoras wanted information, so we would gather it and share, and then they wanted training. So we have our core training, which does meet the C3 and I hope will be accepted by HCI. And we started to develop a lot, probably we have 15 or 18 curricula on issues that were important to them. So it could be on gambling, it could be on reproductive justice. We did a lot of wellness workshops because of the trauma that communities are experiencing, both because of just coming to a new country. And then the pandemic exacerbated that. We really did a lot of work in the community explaining what the pandemic was. But I think the pandemic is an example of the kind of information that we need to get out to our community that's relevant to their language, relevant to their culture, and provided to them by those that they understand and that they can relate to. In particular, we've been called essential workers, but we've been here since before I started 23 years ago. My mother was a promotora. She was the one in the community in segregated America when she would go out and bring information to the community. So many of us have grown up with that type of leader, that type of person. I think what we're asking is that person to be recognized as key to social change and wellness. We focus on them, they focus on their families, they focus on the community. And what you see now across California is many agencies that are now integrating the model or want to know how to integrate it or how to formalize those that have been associated with them as volunteers. The next slide, please. So I bring this up because this is some programs that we have. This one is a wellness program that started because promotoras wanted a place to exercise and to talk to each other. And so we developed this Me Veo Bien, Me Siento Bien, and it talks about nutrition, exercise, and it has a wellness component. It's important because as we start to look at what does the community offer, many organizations like ours have developed these wonderful programs that support the community and that actually could form partnerships with agencies. some have formed these formal relationships, but many like us, this program, Baloterapia, is funded on a nickel and a dime. But we train these leaders in the community. They're certified by us. We carry their insurance so that then they can do these trainings, these exercises in different places. During the summer, they work with Parks and Rec and do them in the parks. And you'll see they do it in different locations and they do trainings. These are the kinds of things that CBOs provide to the health system as a partner, and has been historically, we've been informal partners. So if you'll go to the next slide. The reason I bring this up is because as we start looking at who we're talking about, if you look at the slide on the bottom right side, that's me on the right with a white shirt 20 years ago. But this is a lot of the promotoras and the staff. And if you look at the continuum, you'll see how we're aging. So those of us who were 20 years ago, were young enough to remember, are now aging. And what has brought to mind for us is that we really are looking at this as a continuum, that we start preparing to age well. And that's our mantra. I know that you have a different, if you go to the next page, we'll talk about it. Here you talk about aging across the lifespan. And we integrate this as part of the Alzheimer's piece, because we really want to look at what resources are available for those who have, my mother-in-law passed away from Alzheimer's, and my sister-in-law has Alzheimer's. And so I'm unfortunately intimately involved with it. But I know that all these issues, when you talk about aging across the lifespan, are really important. And I have some names here because I think it's important to us to acknowledge that communities are already working in these areas. They're not recognized, nor are they necessarily funded. But they provide this leadership, they provide the resources. For instance, the Latina Center has a group called Las Palomitas, and they're older adults who get together. Most of them, I think, are over 80, and they get together and they form the support group. They don't go to Resource Center, they don't go to Senior Center, they go to Latina Center, which is a small resource center in Richmond. The Baloterapia I mentioned, that is one way for us to really engage with the community in a way that is supportive. And caregiving is really an important piece that we've moved into. We have a pilot that's for chronic disease and death and dying, looking at the caregiving role in death and dying in particular. And how do we support our families? As I mentioned, two of my relatives have had Alzheimer's. It's a very difficult path to tread. If you're uninformed, it's even more difficult. And so we're developing this project to see how we can go out in the community as promotoras and be that support system so that we can educate and inform, but more often be that emotional resource for the individuals, and especially during the death and dying piece when there's not culturally competent resources. My sister just passed away a month ago, and she was on hospice. And so I've gone through the process of, and what I saw was so many resources were not available to her in her language, in her culture, in a way that was relevant to her and to her family, to her children. And so I think that there's a lot of places where in this span that community agencies can really be a benefit. In regards to the community health worker benefit, I think that it was a great and it is a great idea. But because it's tied to Medi-Cal and to Medi-Cal providers, most of the CBOs are not able to access those resources and those funds. So we've been advocating that there should be a way that we can have a and or if clause somewhere so that resources can come to CBOs who are already partnering. As I mentioned, you see some of these areas that CBOs, small and medium-sized CBOs, are already developing programs that support that individual. So for instance, if I walk out the door and I'm diagnosed with diabetes or I'm diagnosed with early onset Alzheimer's, where do I go for that support? There may not be any culturally and linguistically relevant resources near me. If I live in Madera or if I live in up north near Modoc, where do I find those? Yet you'll find promotoras in most all those places, and we're able to really train them to be that resource in the local community. we do advocate for that, and we've been talking to certainly to HCAT. We've had conversation and much conversation with DHCS on how can we engage and lift up community-based organizations as partners in the Alzheimer, in aging and in wellness. But in the Alzheimer's realm, there's so little known in our communities that we really need to engage us as partners, promotores and CBOs, so that we can help the health community. We can help our when somebody is having an episode at 3 o'clock in the morning, they can call on a promotora to come and help them. We can help with early diagnosis or training. I think those are the benefits of having what we call the army of promotoras available across California. We're really fortunate in California to have a rich heritage of promotores and community health workers. We're out there. I think we just need elevation and recognition, training, support, and funding for CBOs to be able to really play an active role in providing service to our communities. The next slide, please. And this is what we believe in at Visión y Compromiso, working towards a healthy and dignified life. And everything that we do is centered around the family, centered around the wellness for the community, and how we can support activities. So I'm happy to answer any questions. I know that's a short overview of what we do, but we're a large organization, we're strong. And one of the things that we formed recently is a group called La Alianza, which is a coalition of CBOs, small and medium-sized CBOs, so we can help lift up their success at the county level so that they can grow and they can partner with local agencies.
That's really terrific, Maria. Thank you so much for all the good information. I know from other work that I do, just the importance of those community connections and relying on people with the expertise and the connection to the community to help distribute information and lift up the community needs to other places. So just grateful for your knowledge and your expertise. And we want to take a few minutes, and I think both James and Maria are here to answer any questions that people have. People on the committee have questions? Yes, Andrea, please.
So Maria, thank you so much for your presentation. I totally agree with you. There are so many strong communities that are already doing the work, and I don't understand what the disconnect is in regards to larger organizations not partner with strong organization like yourself, because there are so many communities that's already doing the work, and I'm not sure why we are reinventing the wheel when we already have the people that's out there that's trained to do this work. And I think we really, really need to have a conversation about that in regards to the millions and millions of money going towards organization. Why aren't small and strong organizations not getting funding? Because when we're doing these groups and we're doing this work, it costs money. You know, it's necessary because you need to be able to support your cause as well as support the people that are out there doing the outreach. So I don't understand why people that's out there doing the work, they're not being funded or supported. And we do need better partnership because it's already there. I mean, there's no need to have an organization that try to go to these communities or make it accessible when the people are already out there doing the work. And so thank you for just highlighting just one community organization that's doing the work. And she's a prime example of asking for the help and the help not being provided. So thank you.
So Andrea, I think, go ahead, Maria, please.
I was gonna say, Andrew, you sound like you're from the community and you understand the importance of community-based organizations.
Yes.
I think to be very frank with you, I think part of it has been an issue of propriety, that there are universities, there are institutions who have interpreted the role of the promotor and the community health worker in an institutional way and want the funding that goes with it. And there's also an issue of we're considered, quote, just promotoras, you know, that whole diminishing of power and recognition. And we have fought very hard for 20 some years to lift up the recognition and the importance. We are not just promotoras. We may not, like my mother, we may not speak English. We may not have even a high school degree, but we are the ones who can get into the community and really reach community. And I think if we're valued for that as essential workers, or whatever term they want to call us, then we need to diversify the funding streams and really reach those small and medium-sized organizations. We're acting as intermediary for many of them, building up their capacity to have that organizational infrastructure. You know, we're a very large, or we intentionally are a large organization of primarily promotoras. We hire between 180 and 200. I think we're the largest in the nation. We are intentional in bringing in, some of our promotores come in from the fields one day, and then they're working for us. They get promoted to coordinators, to managers, to directors. That's the model that we want to show. That is the potential. You do, if you want to have a report by a DRPH, then give me the money to hire the DRPH. Don't give it to the university. You won't have to pay all that indirect, and I can give you the report. I think it is really reconfiguring who are the experts in the field and how do you support those experts.
I think what I was just going to add is, I think there is this moment in time, and it connects to the work that James is doing, of an effort to fund promotorists and other community health workers through Medi-Cal, right? And I think the challenge is, how do we establish a set of qualifications that doesn't act as a barrier to people being able to provide the services that they are now, right? So, you know, in a traditional sort of medically based healthcare delivery system, you're going to focus a lot on degrees and kind of formal education. And I think we don't want to lose that in kind of the work that James is doing, instead focusing on the community and what are the skills people need to be effective with their communities, which should then enable funding to go through that community. So Andrea, I'm always relying on you, but it's like, you know, James provided, you know, sort of a link to a way to participate in that process and help develop what the qualifications are overall and what the qualifications are for additional Alzheimer's work. And I hope that you will sort of take up that opportunity to bring the breadth of experience you have from your work in the community. And, you know, we heard Dr. Galley say he would love this committee's input about these particular programs. And, you know, if it means blowing up boxes, then it means blowing up boxes, right? So we'll have that discussion at the end about what is a vision of what this could look like to support people who are, you know, often underserved by traditional healthcare systems. So,
Catherine, can I just tag on to that? I think that I was part of a coalition with DHCS that initially did all this discovery and with the information that moved over to HCI that they're developing. But one of the issues for us is that you still have to be a Medi-Cal provider to receive some of these funds. So that leaves out the majority of the CBOs that we're trying, where the promotoras are, and the community health workers in the community. So we're trying to figure out a way how to get around that. And CMS wouldn't allow us to, because it was assigned as Medi-Cal to support Medi-Cal. But you're not going to get communities, you're not going to get CBOs, and you're not going, even no matter what James does and how he opens it up, and there's the 2,000 hours and all those requirements that have been reduced for community-based organizations are not going to be able to qualify unless we figure out a mechanism to allow us to apply for those funds. Now, I was hoping that could be part of the discussion with James. Maybe we can have that conversation later. How can we provide this service to CBOs so that then we can do the back end, or we can do all that and we can still engage CBOs? Otherwise, it's the same system that leaves us out of as recipients of those support funds.
So I think we have a few minutes if you have thoughts about that. And I see Celine also has a comment, but let's do Celine's question and then we'll loop back to say, like, have people thought about what some of those solutions are to reduce that barrier? So Celine, go ahead.
Well, I was just thinking about all these intersections, you know, CalAIM, the Aging and Disability Resource Centers, we're the information and assistance provider for Napa County. And we did hire a community health worker for that very reason. And we got funding through the Mental Health Services Act to be able to have a bilingual, bicultural community health worker. And I'm thinking about your role with Alzheimer Daycare Resource Center. So I'm just wondering how we can kind of, tie all these initiatives that are happening in different ways because we need you in our community. You are in our communities, you are our community to really be part of our organizations. And part of, I know the work that we're doing with the Alzheimer Daycare Resource Center project is looking at that, the health disparities and through all, all the DEI type of issues. And so you really have to be at the table for us to kind of navigate and look at that issue. So thank you for your presentation, Maria.
Thank you. I think a way to maximize or to get to that 18,000 number, for me, it realistically is not going to happen going through a county or through existing systems because the barriers are so narrow and so much of the money is used up by the infrastructure. But really, it's partnering with CBOs. If you go to a CBO and, for instance, if I contract to do outreach and education on Alzheimer's, I could hire 30, 50 promotoras like that. And many CBOs can do that. So you're more likely to reach scale if you partner with CBOs. We just have to get beyond this little thing of who qualifies for the funds and how can we get access to them, which is James, that's you and I having a conversation. But exponentially, you can reach those 18,000 faster if you partner with CBOs. And it's a more relevant model because we're in the community already.
Yeah, and we've talked about this a couple of times already, and I love the conversation, and let's keep it going. In other areas as well, HCI is really exploring new ways of doing things that partners with CBOs more directly, because for the exact reasons that you and the rest of the attendees, have been explaining today, it's not only about scale, but it's about really reaching the communities that need the services now through a workforce that really already exists. So it's like the definition of a win-win-win if we can just partner and get it right.
The pandemic showed us the importance it showed us how promotores are so important. We were lauded for our ability to reach, and this is across cultures. It wasn't just Latinos, it was African Americans, it was Asian Pacific Islander, it was Jakari, with your Asian Pacific Islander. I mean, it was all of us who were in the community, who helped find a solution. So we're out there. I keep saying we're an army of promotores and community health workers. We just need to find this path to be able to join together and to support, for mutual support.
So appreciate all of that and just the thinking that goes on of how do we transform systems to allow for a larger diversity of services and at the same time allow the state to get the federal dollars that they're trying to get to support these kinds of programs. So I think this is another area in which it would be just great to have a report back on occasion about how you're threading that needle and bringing into the system the strengths that the promotorists and navigators from other communities provide. So really a lovely opportunity. And Celine, I just really wanted to call out sort of your comments about the Aging and Disability Resource Centers and recognize your commitment to bringing in a community health worker. And I think those kinds of connections of knowing who exists in the community and how ADRCs can use the existing other CBOs as a resource for community members that might want to use that kind of assistance. So just it seems like you're taking a good step forward in terms of doing that. So thanks for calling that out. That was terrific to hear. Any other comments, questions? So we are actually a few minutes ahead of schedule. Is that remarkable? So I'm going to hijack like 2 minutes of that time. Say thank you to our speakers, good information about how to contact James. Thank you to Maria for all that you brought. Maria and I actually share, we went to the same undergraduate school. So lots of good work happening at UC Riverside and good people that came out of that. But I want to get our minutes approved because Michelle remind me that we need to do that. So I thought we might just take an opportunity to, you all got a copy of, the committee members all got a copy of the December meeting minutes, and I hope you've all had a chance to look at those. And oops, sorry. Wanted to see if there were any comments or corrections to the minutes. I'm not seeing any. Would anyone like to make a motion to approve the minutes?
So moved, Todd.
Thank you, Todd. Is there a second?
A second, Meg.
Thank you. Thank you, Meg. Any other discussion about the minutes? And thanks to Michelle who prepared them for us too. Okay, not seeing any other discussion. All in favor of approving the minutes, say aye. Aye.
Aye.
Aye.
Any opposition? Any abstentions?
I abstain because I wasn't at the meeting.
Thank you, Derek. Okay. All right. So with that, it's 11:55. So Michelle, would you prefer that we come back earlier? What should be our protocol?
Yeah, how about if we come back at 12:30?
We will be back at 12:30. So you get a nice lunch break and a break from information overload for a minute because there's so much good information being shared, and we will see everyone at 12:30. Thanks, everyone. See you then.
Thank you, everybody.
A few more people. Michelle, do you want to let us know when we have kind of critical mass to get started? Seems like we're getting there. People are so prompt.
Sure. Just a second. It looks like we're good, Catherine.
Sounds great. Thank you. So as always, we are really fortunate to have two of our partners, Barbara McClendon and Jared Jeruso-Clark, do a presentation, a little legislative update, and then we're going to have time for some questions and answers. So really look forward to what you have to share with us, Barbara and Jared. Thanks for being here.
Thank you. So I think Michelle's going to start our slides. We'll see who comes up first, if it's mine or Jared's. It's mine.
It's yours.
So as Sarah said earlier, the governor's budget, I think all of us in the aging space and specifically in the Alzheimer's and dementia space, we're glad to see that there weren't significant cuts proposed. And so now our attention turns to the legislative session. Bill filing has been, I mean, this is typical, slow. And then as we approach the deadline, which is February 17th, it will become a tsunami of bills. And so I don't know how this committee, because if I think about when the next meeting is, I don't know how we might want to handle taking a position or maybe being in support of legislation, because we'll have a much clearer sense after the 17th of what the landscape is as far as policy bills and budget requests. So maybe that's something to think about. But I will start with the policy bills, and actually they both have budget requests too, that Alzheimer's Los Angeles is going to be pursuing this legislative session that of course we would love to have this committee support of. So if we can go to the next slide. So this is just to start us off. This is what our policy platform priorities are. Oh, and I should also say that we do our public policy in a partnership with Alzheimer's Orange County and Alzheimer's San Diego. So our three organizations have representation in Sacramento, Monica Miller, and so all of the legislation that the two bills that I'm going to be talking about today all three of our organizations are putting forward. And our priorities, generally speaking, in our two bills support these are expanding access to home and community-based services, supporting family caregivers, building a dementia-capable workforce, which we've talked quite a bit about workforce this morning, which is fantastic. And then addressing cost of care, which Sarah spoke to briefly with the LTSS benefit discussion that is ongoing at the state level. And we certainly hope that sooner rather than later, that actually results in a benefit that people can take advantage of. Next slide. Okay, so diving in, you can go to the next slide. So I will say also that both of these issues that I'm going to bring forward, they do have sponsors, but in the interest of not jinxing anything, I'm not going to say who they are until they're actually across the desk and we have bill numbers. So, but you will see both of these ideas as legislation with bill numbers. I just don't have that today. So the first one, and I know in our following our conversation here, we're going to have a presentation on Dementia Care Aware, which is fantastic. It's a really wonderful program. And so this idea, which we did put forward in a different form a bit last year, and we did get funding for in the budget, and then the governor removed it from the budget. So we are coming at this again, but from a more holistic perspective. As Dementia Care Aware rolls out, one of the goals of that program that I'm sure Dr. Chodosh will speak to is that we hope here in California, we do a better job of screening people and assessing them for their cognition. And so if we can get better at diagnosing people accurately with Alzheimer's or another form of dementia, which our aging population indicates that that's the direction that we are likely going, that means we're going to end up with a whole bunch of folks who are going to become family caregivers. And so we would like to see expanded access to that whole suite of services that we know caregivers need. So the education for sure, and how to provide quality dementia care as a family caregiver, but also the support groups and all of the respite care, the resources that they need. So this would be structured as a pilot and would provide funding. It would be a competitive bid process with a real focus on underserved, historically underserved communities. So because those are some of the communities that we know need these services the most, and we'd like to expand access to them. So that's what this would do. I do not have a dollar amount for you on this yet. That is all being worked out. So we'll go to the next one. So this has grown out of an initiative here in Los Angeles County. There are other counties across California. San Diego is one of them that has a program that attempts to help families prevent wandering. That could be an older adult with cognitive impairment. That could also be someone living with autism or another developmental disability. Wandering is an issue across both of those communities. So we built a program here in LA County. We were aware of San Diego. There are some others in Ventura, but it's a patchwork. And of course, when someone wanders, they pay no attention to county lines, cities, frankly, states and countries even. It's kind of incredible how far someone can get when they wander. And so this would create a task force housed under a state Department of Justice and their Bureau of Missing and Unidentified Persons to build recommendations, just like what we did in LA County, for what could a county do to build a better system to support families, prevent wandering in the first place, and respond more effectively if and when someone does wander. And it would not be requiring anything specific from any county. It would just be building resources and hopefully having those conversations about how we can do better with coordination between agencies across the state. And I think that's it for me. And I think, Jared, and I'm assuming, Catherine, you want to do questions after we're all done.
That'd be great, I think,
Great.
if you don't mind.
Yeah.
Thank you so much. Thanks for the
problem.
presentation so far.
Well, thank you all so much. Thank you, Barbara.
Welcome, Jared.
Thank you. Thank you. thank you also just for allowing us the opportunity to present on some of our bill priorities and just to kind of give you, as I think Barbara did a kind of a broader overview of what we're seeing in the legislature. Can you advance to the next slide and maybe even the following slide? Yep. Perfect. So just like Alls, LA, Orange County, and San Diego, our association's state priorities are guided by these priorities. I always keep this in every presentation that we do, and I think very much our priorities, just like Barbara's organizations, really are aligned with what we see in the master plan, with the Alzheimer's task force, and many of the conversations that we see happening at this advisory committee. Next slide. So this year we have a number of legislative and budget priorities that we're looking to advance. We have a few of them introduced, and then there's another one that we're still kind of working on. So next slide, please. As all of you probably are aware, last year we moved forward a bill, AB 2583 by Assemblymember Mullen, which was dementia training for peace officers. That bill was held in the first House Appropriations Committee, and with the Assembly member transitioning to Congress, we were fortunate enough to have the support of Assemblymember Mike Gibson, who has prioritized law enforcement reform in the legislature and was interested in our bill efforts last year and decided to reintroduce the bill. There's very little that's different about AB 21 to AB 2583 last year, but given the deficit that the state is currently experiencing, $22.5 billion in the January budget proposal by the governor, we're trying to be as mindful as possible about cost of the bill. Last year's bill cost $13.5 million to implement and $1 million in ongoing funding. So the only change that that you'll see in AB 21 compared to AB 2583 is an exemption for jurisdictions that are currently doing Alzheimer's specific training for their law enforcement. The thought there is that that would draw down the cost. And we've been in collaboration with POST, the Commission on Peace Officer Standards and Training, to evaluate other options if we need it once the bill gets to appropriations, to be able to modify cost as well while preserving the intent. The bill is slated for Assembly Public Safety on February 14th. Last year it was on consent, but who knows what'll happen this year, although we feel fairly confident about how we're standing in that committee and would love everybody's support on that bill. If you could move on to the next slide. So very, very exciting news. Actually, just today, our bill by Assemblymember Aguiar-Curry that updates this Alzheimer's Advisory Committee was introduced. It was passed across the desk. Today, we have a bill number, AB 387. And this bill takes a key component of AB 1618 by Assemblymember Aguiar-Curry from last year and moves it forward, which is the update of the advisory committee. You'll see some of the things that, in close collaboration with committee members last year, we're bringing forward this year in AB 387. We're so grateful for that ongoing conversation, that dialogue, and that feedback that helped us to understand some of the additions that needed to be brought to the committee, stigmatizing language that needed to be removed, uplifting diversity as a priority for the advisory committee, and then through committee debate, we also included the ability for the Secretary of HHS to appoint additional members up to 25 as needed. So, while we are so appreciative of that input and that feedback that got us to where we are now, this bill is, in many ways a new bill. So, we're also looking forward to, continued dialogue this year. If there are things that you all are thinking could be made to make this bill stronger, we're very much open to that engagement. And we're hopeful that this bill carries with it no fiscal impact to the state, so we can avoid the treacherous appropriation committees. Again, we're happy to continue the conversation. Myself or Amaranto Marcelos, who is our advocacy manager, who's been staffing this bill for us, very much happy to start a dialogue if there's input or feedback on this bill as well. Moving to, I think, my last slide. So, as you all know, the California Alzheimer's Disease Centers are absolutely crucial to a number of the priorities of this committee. You've already kind of discussed the role of these centers, how they are uplifted in the Alzheimer's Task Force report, and how they really help advance many of the master plan for aging Alzheimer's priorities. You may also remember that last year, the centers put forward a request for additional funding that I think was moved forward through this committee to the secretary. And we have been unfortunately, that funding did not occur. And we have been working with the directors of the CADCs to come up with a budget request for this upcoming year. As I've already mentioned, the state has a pretty significant deficit, and I think that has made it more challenging for legislators to move forward any kind of new spending opportunities or ongoing new spending obligations for the state. But we have been encouraged by legislative champions to think about what a request to support the CADCs could look like, potentially in a year where nothing new will be funded. So I will say that we do have at least one commitment from a legislator to introduce a bill on the CADCs this year that potentially would either carry with it a budget request for either this year or for next year. If it's next year, this is really our opportunity to gain support amongst the legislature and to be well positioned for any opportunities. But I did want to mention a few key kind of thoughts that we've been having and conversations that we've been having with the CADC directors. So first, I think, ideally, we can all agree, with our association's perspective, as well as the CADCs, that with the exciting advancements of therapeutics, the CADCs should really be at the forefront in ensuring Californians have true access to a timely and accurate diagnosis. We think that work is more important now than ever and will continue to grow as being so important to ensure people have access to whatever therapeutics come online. Secondly, given the work of Dementia Care Aware, which our association is keenly interested in because of our work on SB 48, but is also highlighted in the new iteration of the Master Plan for Aging, which you all heard about earlier, and has already kind of seen key kind of linkages to the CADCs, but will completely run out of funding in March of next year. We are also trying to think about what that longstanding or ongoing relationship between the CADCs and Dementia Care Aware could be, given kind of the relationship that already exists. And then lastly, I think we're very much interested in how the CADCs can be equity focused, and then how they can, be strengthened to serve through their many arms in the community, all Californians impacted by dementia. So, I think by our next advisory committee meeting, we'll have more to share, likely a bill that's introduced that spells all of this out. And we're excited to talk about that more with the committee when that happens. The last thing I'll mention, and Barbara touched on it, we're seeing a slow going of bills that are being introduced that would be relevant to us as an association as well as the committee. And so we're hopeful that if we're invited back to present during the next committee hearing, that we be able to talk about some of the bills that we've seen introduced that are Alzheimer's specific. I am familiar that today another Alzheimer's bill was introduced as well by the Aging and Long-Term Care Vice Chair, Assemblymember Ta, who is, I think, moving forward a bill by Assemblymember Vopel last year related to Alzheimer's public health. So we'll have more to share, more information, I'm sure, by the next committee meeting, and excited to, again, continue this dialogue.
Thanks so much to both of you. So my impression is, and I would love Julie or Michelle or Susan to sort of give us opinion about that is that we're an advisory committee to the secretary. That's how we're set up, and we give advice to the secretary about things, but we don't take our own positions about bills in the legislature. So I think that's our role, but I haven't been here for the whole history of the advisory committee. So welcome any of the staff providing input about our role, just as that's appropriate. And then in the meantime, really look forward to any questions that people have about the very beginnings of a 2-year legislative cycle that will continue to evolve. So we'll ask if any committee members have questions. Pam, and then Todd.
Hi, I don't know if it's appropriate to talk about it right now, but when Jared was talking, it reminded me of my story of when I went to my primary care doctor and I told him that I was having, issues, and I don't even remember what I told him. And he said to me, well, you don't look like you have Alzheimer's. And so, yeah, I'm like, okay, well, I guess, because I didn't know anything about it either. But that has been like a frustration. And I think for so many people that there are primary doctors out there that don't understand what early stage looks like. And I don't know if there's a bill, maybe there is already, but it's just kind of a little something that bugs me. And so I wanted to mention it, Jared, for you. And, you know all the bill numbers. I don't know any of them because my brain doesn't work anymore. But anyway, I just think that's just something that we really need to take care of, and to make sure that they're getting more education and that people can look like they're 20 or 30. They don't need to look like they're 80 before they need to go to the doctor.
Thanks for that reminder, Pam, really important. And I think a number of the things we're going to be hearing about this afternoon also address exactly that point. So really good point. And I think Todd had a question.
Yeah, I just wanted to speak to the wandering aspect. I think that is a really important initiative. As everybody I'm sure on this call knows, there is no prediction of wandering once dementia and Alzheimer's is in place for any individual. And San Diego County really had a model program with the San Diego County Sheriff's Department called Take Me Home. And it's basically like a registry. So it works very much like the Amber Alert within the county, and could cross jurisdictions to San Diego Police Department and Fire. And we really need something like that network statewide. And they also were very inclusive of anybody with autism, any kind of intellectual disabilities. Any of those adults are at risk for wandering and being lost. And time is of the essence, as we all know when we read this horrific stories in the newspaper, that within the first 24 hours, if somebody's not found, the risk goes up tenfold for them being found alive. So the demographics in the state are changing, and in the nation so very quickly over the age of 80, that we've got to have a really viable network and a registry in place in California. I've been doing this for 30 years, and it really hasn't advanced much further than the program here in San Diego County, but we really need to model that and take it statewide.
So Todd, just one question, is that the program in San Diego is still ongoing, right?
As far as I know, yeah, we used to meet on a regular basis with the Alzheimer's Project Committee in the county, and would get updates directly from the San Diego County Police Department. There is still a registry. We encourage all of our family members to register their loved ones when they move into one of our communities. So it's still active as far as I know.
Good. All right. Thanks for that. I had one question, Jared. I think there was some discussion, and I didn't see it on the slide, although I might have missed it, about revising the name of the committee. Is that still happening, or this committee as part of the bill that you mentioned? SB 387, I think, whatever the number was. Or AB.
Yeah, AB 387. Good job.
Yeah.
So I'm having to remember it now just because it just was introduced introduced. We are still very much going to move forward a change of the name of the committee from Alzheimer's and Related Disorders Advisory Committee to Alzheimer's and Related Dementias Advisory Committee. I'm not sure if that was in kind of the draft just because of the timeline for introduction, but if it isn't, it'll be there when it reaches first committee, and I can confirm with our staff as well to see whether or not it's in or not, and then let you know tomorrow.
Thanks so much. Appreciate that. Other comments or questions about legislation? Julie.
I can jump in. I think I just want to make sure I have your question correct, Catherine. I think it's really what is the role of the advisory committee on active bills and making recommendations on those. And I think because the formation of the committee, I think what I would suggest is capturing any specific viewpoints that the committee has on legislation in the secretary memo, so that as the bills are moving through the process and our departments are evaluating those bills and putting forward their internal recommendations, that the secretary has the information to take that into account. So I don't think it needs to be like a formal action, but can capture it in the secretary's memo. That would be my suggestion.
Thank you. Thanks so much for clarifying. I think, as our membership changes, we're all a little uncertain sometimes, sort of what's our role and the best way to proceed. So appreciate your wisdom and knowledge about all of that. So when we get to that, I mean, now, as well as when we get to that section of the report, I think that's good information to give. We gave the secretary some recommendations last year about the composition bill. Several members of this committee worked to sort of refine what the composition looked like, and that was an incredibly valuable process, I think. And I'm glad to see that it reflects all of the wisdom that this group had last year. So I think we were influential in that way. And I guess my other question is, I think it was you, Jared, that was talking about the research centers. And did I hear correctly that the current funding expires in 2024 or 5, something like that? Or
yeah, so not to confuse the issue, the Alzheimer's disease centers have ongoing funding. I think it's roughly just over $200,000 per center for all 10 centers. That continues. But Dementia Care Aware, which is funded by the HCBS spending plan, they will run out of funding in March of next year. And so I think because of the relevant connection between the two, and given that we might be moving forward a policy conversation on the issue, there could be a bridging of those two things through the legislative effort.
And is the reason they run out of funding because it was American Recovery Act funding, or this? Right, and that's when that just naturally expires, right? And so now there's an opportunity to think about how best to fund those for California. So that's something I think the committee can kind of take up in the recommendations to the secretary about that, and it kind of ties nicely to our next presentation as well. So I'm not seeing any other comments from or questions. So with that, Derek, who has a wealth of professional and personal experience with dementia and brings all of that to the committee, has graciously agreed to lead the next discussion, including facilitating the questions about Dementia Care Aware. So I'm going to turn it over to Derek with a big thank you for taking on this role.
Thank you so much, Catherine. So today we have 3 guests from the University of California, San Francisco, who will provide all of us an update on Dementia Care Aware. So first of all, I'd like to introduce Dr. Anna Chodos, who is the principal investigator of the Dementia Care Aware. And then joining her is Danielle Taylor, who is the director of operations, as well as Clara Park, the director of strategy. So without further ado, I'd like to turn over to Dr. Chodos so she can provide us with an overview and an update. So over to you.
Yeah, absolutely. And really want to thank everybody for having us and allowing us to provide this update. And was glad to hear, some conversation about our program, and grateful for you guys wanting to learn more. So we're going to go over an overview of the program, our sort of foundational work in something called the cognitive health assessment, which was really the legislative mandate to create that for the state. Why dementia care aware is important. And I wasn't able to get on early enough, but I did hear some discussion about detection and early detection of dementia or mild impairment. So really highlighting some of what we're hoping to impact. And then our accomplishments so far and our year ahead. Just want to check in with my team. Is it okay if I proceed, or?
Oh, Anna, I can do the first couple of slides. If that's
Okay, sounds good. I thought.
And then I'll hand it back to you at some point. All right, thank you. And I'm sure most of you all are aware of Dementia Care Aware, but wanted to just give a brief overview of who we are. We offer provider training and support in culturally competent dementia care. The bill was passed and signed in March of 2022, and we have until, as again, Jared mentioned, March of 2024 for our program. Between these 2 years, we are creating and disseminating training, supporting primary care, and implementing the training and improving dementia care in general. So overall, the goal is really to empower primary care serving Medi-Cal patients to improve their screening, detection, and care of those living with dementia. I do want to point out that as we were incorporated into SB 48 and the way that we were kind of born as a program, we were focused on Medi-Cal, but very quickly we kind of pivoted and made sure that we are not just focusing on Medi-Cal patients, but Medi-Cal, Medicare, and dual eligibles, understanding that the services and the trainings that we provide really should be offered to all of those patients. Next slide, please. So we are a California statewide program. Again, we officially launched in March of last year, but again, we had to go through kind of the beginning stages of setting up a whole statewide program. Our first couple of team members were hired in May, for example. And then we have all of these amazing partners across the state. As you all probably know better than we do, there's just so many great experts and organizations out there doing really great work with Alzheimer's and dementia. So we really wanted to make sure that we were partnering with all of these specialists and experts. So here are all of our really, really great partners. We wouldn't be able to do the great work that we do without them. And really the past 6 months or so have been spent on making sure that we have really strong partnerships with all of these organizations moving forward. Next slide, please. So we like to think of our program as having 4 main pillars. So the first pillar is around education. So we do have online training modules available right now on our website. Our cornerstone module is around the cognitive health assessment, which again, we'll talk about in subsequent slides. We also offer regular webinars. We've been hosting monthly webinars since July of last year. And then we also offer podcasts, which we'll also talk about in subsequent slides. All of these educational offerings, we have continuing education credits tied to them. And then the second pillar is around outreach. So again, we're a California statewide program. Our hope is to really reach out to all primary care providers here and trying to reach all of them in all 58 counties in California. We're doing this through a lot of different events, in person as well as virtual events. And then we have a very exciting media campaign that's going to be launching any day now. So we'll hear a little bit more about that as well. And then the third pillar is health systems implementation. So understanding that, of course, we're offering these educational modules and trainings, but we also wanted to provide more resource support. So our website does have a lot of practice support resources, and we're constantly adding to it. We launched a warm line for clinicians. So currently it's a website form, so you just fill it out online. And this is meant for clinicians to kind of get real-time support and decision-making around dementia care. We also have ECHO conferences, which are, of course, virtual teaching conferences, and then have partnerships with other organizations that really provide amazing hands-on coaching around dementia care. And then the last pillar is evaluation. Of course, we have 2 years, as we mentioned, and we have all these great activities going on. We want to make sure that we're capturing as much of it as possible. So we're tracking kind of process and outcome measures, and we're also doing some sort of a mixed methods analysis. So tracking quantitative as well as qualitative methods. And we're really trying to understand kind of the uptake and usefulness of our training, as well as understanding any care gaps that emerge in dementia care. Next slide, please. So this is the cognitive health assessment. As I mentioned before, this is really the cornerstone of our training, meant to be an annual assessment for patients 65 and older. It should be very quick, so roughly 5 to 10 minutes. It's an assessment on the patient's cognitive and functional symptoms, as well as an assessment of their support system. This is meant to be the start of a diagnostic assessment and really a jump start on their overall brain health. And as I mentioned before, we do offer CME, CE, and MOC credits so that providers can really find this useful for them. Next slide, please. And I believe I'm handing it off to Anna.
I appreciate that. I've been a primary care provider here at San Francisco General in our outpatient setting since about 2008 with training and post-training combined. And now I do consultative geriatrics and dementia care for primary care. So this afternoon, I'm in a primary care clinic seeing folks, patients, and what I call sort of just a co-management approach, but it's just me. So I don't have other team members that I would love to have and that we know are so important for good dementia care. But the bulk of my evaluations really are on dementia. And I think I appreciate every day, and this slide is meant to give us an opportunity to share with you. I heard briefly, you guys were already talking about this, but detection in primary care is challenging and inconsistent at best. And we know a lot about why. In fact, it's folks in California and people at UCSF who've contributed to some of that research, a lot of it qualitative about what those gaps are and why they happen. So we know that providers miss or don't detect dementia in part because education is not really caught up. So foundational education in medical school and training isn't really adequate for many providers. And then a lot of providers endorse that they really feel uncomfortable with the assessment tools that are available and the protocols. And there's a lot of conflicting information. I think this gets even more true when we're talking about populations that speak a language other than English or have varying cultural or educational backgrounds. So I'm from a rural area. I had only a couple of years education and I speak a language other than English. That might be someone who the tools that we've been trained on, if we have, are pretty inadequate and inappropriate even. And so people feel uncomfortable with a lot of the tools that they're sort of handed to assess to begin with. And then we know that actually there's a lot of folks who sort of indicate in the chart that they think this is going on or they even know this is going on, but it's not clearly diagnosed or disclosed to the patient. And there's some evidence to suggest that that has to do with some of the stigma around a dementia diagnosis and nihilism around what we're going to do about it as a healthcare team, as a primary healthcare team. When providers were asked about what would help to support them in detecting and addressing dementia, 64%, this was in a California safety net study, said that they were highly confident in providing general medical care to people with dementia. So we're going to use the term neurocognitive disorder here, NCD, but we mean dementia essentially. But around specifically for the neurocognitive disorder, only 21% felt confident, highly confident in recognizing when a patient had dementia. Only 13% said they were highly confident in giving and delivering a diagnosis. And then only 20% said they were highly confident in interpreting test results. So it's a lot of the same themes of discomfort around detecting, doing the clinical assessments with the diagnostic tools that they know about, and then talking about it with patients. And it's taken me a very long time to get comfortable with it. So I definitely understand where they're coming from. Next slide, please. But we know that early detection is extremely important in dementia, as it is, timely detection is important in every condition that we can, help patients with. And it's a key feature of high quality care. So in dementia care, where we really want to emphasize how we can help providers make timely, earlier diagnoses than they might otherwise, not necessarily early by some measure of the disease or preclinical or something like that, but certainly timely with regard to the patient's course with the disease and earlier than we would have otherwise. And that this should be considered a key feature of quality care for this condition. And the evidence is really abundant that early detection does allow for identifying and treating reversible conditions. There aren't many that would totally reverse symptoms, but certainly make them much better. Now we have, of course, increasing options potentially for slowing decline, depending on what's going on with the person. But honestly, things like correcting hearing radically slow decline, encouraging exercise. So these are really, doable interventions. Depends on the person, and their resources may not always be affordable, but that, of course, is another issue. It allows people to be educated, learn more, know about their health. That is a big factor, and a lot of people expressing satisfaction with care and feeling empowered, and more time for care planning. And as Clara was saying, so many of the people on this call and so many of the people on that slide and organizations that you saw are the people doing this incredibly important work around really, really meaningful care planning and support for especially care partners or people, if they don't have a care partner or caregiver, making sure that they're supported in other ways in just what's important in life, planning all aspects of life, but especially those around what might come up with increasing cognitive and functional decline. And so allowing people, patients and families to prepare is a key feature of this. And then finally, timely referrals for the education that we know makes such a difference in high quality of life as people have more and more symptoms, the caregiver counseling and support, and social services. So we really want to emphasize that an annual approach to screening with the cognitive health assessment will lead to timelier identification and diagnosis and much better outcomes with regard to quality of life, treating reversible conditions, and maybe some point here soon, more universal access to certain treatments. Next slide, please. There's also a lot of overlap, and many of the people here actually have educated me a ton and may even be better poised to speak on this in detail, but just wanted to point out briefly that we know that there's going to be more responsibility for folks, insurers and plans through CalAIM and other initiatives to make sure that, people are responsible for the continuum of care. Long-term care is a huge issue with dementia. People with dementia, living with dementia, are high users, of course, of long-term care. And so this is a very relevant issue. So how do we intervene sooner and help delay any need if there is going to be one for long-term care, as part of some of these programs with the long-term care carve-in and the enhanced care management program. So there may be some opportunity to just synergize with these efforts and these new ways of caring for folks and addressing all the social determinants of health and other care needs that aren't as strictly medical. And the dementia population is a key one that this would be relevant to. But who are those folks? I think that, again, that it keeps coming back to the issue, are we identifying folks and are we identifying them early enough to be more responsible for these aspects of their care? Next slide, please. And then DSNPs, I think enrollment is higher in Southern California. I know in Northern California, we're haven't seen it as much, but there's also a quality measure around reporting screening for dementia. So the cognitive health assessment that we've developed and gives people the tools to do that annually could be a way for providers to meet this quality measure. So as DSNPs expand for dual eligible recipients or beneficiaries, excuse me, I think the cognitive health assessment and dementia care aware program overall could be a really tremendous resource. And we just hope that at least our resources and our tools are available at the same timeline that are needed for folks to get on board with this benefit and requirement. Next slide, please. So I just wanted to briefly mention, if you go to our website, which we are revamping and will look a little different within about a month, we have one online module, which is the cognitive health assessment. And really want people to be very familiar with that as they look at some of our other offerings. But within the next few months, we'll be releasing additional online modules that provide continuing education credits. So we're really hoping that's an incentive for people to do the modules and to learn. But we're really trying to hit the core areas of need and of practical implementation for primary care. So for example, how do I do this with my team so that I, as the primary care provider, don't have to do the whole thing? How do I do it using a telehealth model as we're moving? I know my clinic's moving very swiftly to a lot more video visits and phone visits. Even after the pandemic, we're still doing this. Adapting the cognitive health assessment for people's needs around language, developmental disabilities, serious mental illness, and other very, very common issues that come up when you're dealing with regular patients day to day. What to do next after you get a positive screen for the cognitive health assessment. So starting to get people down the road of getting to a diagnosis, advanced care planning and legal resources, and then working with care partners and caregivers. And we're almost at the point of releasing, we know everybody's got a million podcasts that they listen to, but this is one more, and we want to make them short and very digestible so that providers can get the information and healthcare team members can get the information or learn things about dementia and dementia workup and get credit for it as well. So we're offering CME. So we're kind of trying to put it as many formats as possible, also to make sure that people get as much exposure to the material or find a way that works for them to learn it. So definitely look out for that. And I think okay to go to the next slide. Great. And I will pass it to my Director of Operations, Danielle.
Thanks, Anna. So as Anna was introducing before, we are trying to have all of this content delivered in ways that people can digest. So another way that we are delivering educational content is through monthly webinars, as well as Echo series, the case conferences through UC Irvine. We have one coming up with UCSF, and then also the Alzheimer's Association has these Echo series as well. We have a monthly webinar series that covers topics similar to that mentioned in the additional modules. So it's really intended to be kind of, you can access this information through different modalities. So our upcoming webinar, our next one is on Tuesday, February 7th, around assessing and connecting with the caregiver. We've had great attendance at these webinars and have gotten positive feedback from attendees. So we'll be releasing these on a monthly basis, and all of these can be found on our website, and those who attend live can also receive continuing education credit as well. So if you want to attend, we have the QR code up there now. You can scan and sign up and register for the upcoming one. And we also have an additional one later in February, I believe, on med legal topic. Next slide. And as Clara mentioned before, we have these pillars of our program, and especially as a newer program that has spent approximately 6 to 8 months really getting off the ground truly once we launched in July. We really want to get the word out to as many folks as possible, also considering that we are a statewide program. So we have a marketing team working with us on paid media and advertisements so that we can reach a broad number of primary care providers across the state. So they will be doing kind of targeted marketing via online ads through a campaign. And that should start sometime this week, actually, because we are in February 2023. And we're also working on a PR campaign. So trying to figure out how we can leverage existing media channels to promote our program. And that is slated to start sometime in March. And then we're also finalizing our social media posts. Will be on LinkedIn and I believe Facebook at this time. So we're finalizing those posts now to go live in February. Really just trying to put our name out there, get awareness, and drive people to our website, our training, and our services. Another way that we're reaching folks is through our partner organizations. We're working with the Alzheimer's Association, ALS LA, and ALS OC to conduct outreach to Warm and Cold Connections. So they are working through some of maybe their existing relationships that they have to introduce the program, really speaking with individuals about the program and, understanding whether or not, how to drive them to take the training and get feedback from them as well. We're also attending conferences and events to promote the program, to promote Dementia Care Aware. And we've established mailing lists and listservs that folks can sign up for to get regular updates about upcoming program announcements and events. Next slide. And Clara had also mentioned before, and I don't know if Anna alluded to this as well, but we have a warm line, which we're really excited about. It's a provider support and consultative service. So really wanting to help provide decision-making and consultative support to clinicians and primary care teams. Currently, we have a form on our website that folks can fill out with questions, comments, concerns, and we would get back to them within 2 business days with answers, hopefully sooner than that, but up to 2 business days, just to provide them with resources, feedback, answer their questions, direct them to the correct place based on their questions. But in March, we are finalizing a full phone warm line. So this warm line is intended to be a phone line that providers can call between the hours of 9 a.m. and 5 p.m., where they can get real-time support with any questions that they have. So some examples of potential questions that we might receive are in these cute little blurbs. So is the cognitive health assessment covered for patients over 65 who have Medicare but not Medi-Cal? How do I prioritize after a positive health assessment? So essentially questions that could help them work through how to implement the cognitive health assessment in their practice. And yeah, we're really excited about this service and hope to provide that starting in March. Next slide. So I look back every now and again and think, oh my gosh, we've accomplished so much, and it's really cool to put it here on a thing. This is not even all of it, but this is just some of the highlights that we thought would be important to share with you all. But we've developed the core module, and we've had over 180 completions in climbing. And as my other colleagues referred to, we are creating additional online modules to be released, which we are really excited about. Our webinars have been a huge hit. We've had 5 so far with a total of 706 attendees, and we will be launching again 12 more, one each month for the rest of the year. We also have the podcast, and we are really just driving more engagement through our listservs. And I was really excited to see that our first monthly newsletter had a pretty good open rate. So we hope that people are continuing to engage with our communications and sustain through contact efforts and our communications efforts to really drive folks to access these really amazing resources that we have built or collated so far. Next slide. So kind of just to summarize all of the efforts in a little bit of an analogy is that we're really revving up the Dementia Care Aware engine. The second half of 2022, as I said, we were getting all the pieces together, getting all the things, setting the foundation and framework for our program, which we built almost entirely from scratch. And we're really, really excited for 2023. It felt like this month of January was really a lot of the moving pieces slotting together in a very exciting way. And we are really excited to start strong through this year and hit the ground running with many of our initiatives. And next slide. And so how can you help? We always love a call to action at the end of a presentation, but we really want folks to learn, sign up for our newsletter, receive updates, really engage in some of the opportunities that we have through webinars as well. We always appreciate kind of potentiation of our information. We have our listservs, but we all know We all know that everyone on this call has a network that might be interested in this as well. So always asking to share with your network and give feedback. We're really learning, we're iterating, we're in the early stages of our program. So if you have any feedback, comments, questions, or concerns, we are always welcome to hear those as well. I think that might be it. Next slide. Thank you.
Well, thank you so much to Claire, Dr. Chodos, and also Danielle for sharing with the committee about the dementia care aware. It reminds me back in 1990, UCSF actually had a memory clinic, and that's when they piggyback with the Chinese community to do a lot of diagnostic workup with Chinese-speaking individuals who are suspected of having dementia. So really this has come a long way. So I just have a quick question, and then I will turn to the rest of the group, to ask. So knowing that you're going to have an annual cognitive health assessment, which I think is very, very important, has there been any thoughts about extending that? So what if you need some confirmation? Will there be any kind of brain scan to confirm the diagnosis so that for sure this individual is being afflicted with dementia?
Yeah, so first of all, I think the other big picture thing about the program is we want to really support all the other work that's already been done for so long in dementia across the state. And that includes all the incredible organizations across the state that are doing a lot of support either for healthcare or for community organizations and just direct to patients and caregivers. So one thing we want to highlight is CDPH has a toolkit. San Diego has a dementia toolkit for that they developed with, I think, Champions for Health. It's a totally beautiful toolkit. And then there's some other initiatives across the state that help support the next steps. We have a module, we did a webinar, and we have a module on what you would do next and how you would think through what the next steps in diagnosis would be. And what we're trying to do conceptually is really create and highlight for folks kind of like a roadmap, where am I now? Okay, I did a screening, there's this result, where am I and what would the next steps be? And for whom is head imaging appropriate? And when can I feel comfortable using certain words like dementia and then dementia due to blah, blah, blah. And and trying to encourage providers and give them the tools to be more direct with patients and caregivers that that's what's going on. And yeah, I totally look to colleagues here like Dr. Mobley, who have been part of other efforts to make that part of the workup really clear. There is, I think the CDPH toolkit is if people are really, really Alzheimer's typical, and especially in later life, that I don't know that there's a stronger recommendation to confirm with head imaging specifically, things like that, but we're trying to make sure that people do have that list of things to do. And at this point, maybe previously head imaging or certain diagnostics were more challenging and now less so. And in fact, it's kind of the other way, where can you get a amyloid PET scan? There are research ways to do that. How can we connect you to a CADC that can help do next level diagnostics for some folks? So there's actually a model in Georgia where they basically created a statewide hub to get people to essentially memory hubs across the state so that they would get the full workup. And that is a very inspiring model. If we really encourage people to screen, we want them to know what next steps would be in terms of social services in their area, caregiver support and next level diagnostics. So very long-winded answer to your question, but yes, we're trying to be clear with where people are in their roadmap of doing the thorough workup for these issues. But I guess the big message is let's just start also with annual assessments and screening.
Thank you so much, Dr. Chodos. Any questions from the committee? Barbara, you're next.
I just want to underscore that some really extraordinary work has been done, is being done between the CalAIM program and Dementia Care Aware to improve care across the continuum for people living with a cognitive impairment and engaging their caregivers. And the new quality measure that the state put forward, I mean, that looks maybe very boring on a screen. Like, how many people have been assessed? And we could talk about, like, how is the state defining assessment? That's actually an important question to be asking. But that would actually be incredibly helpful to those of us who are in the advocacy space to get that kind of information, because the answer to that should be 100%, because Medicare says everybody should get an annual memory screen, right, as part of their annual wellness visit, but it is not happening. And so if plans start, it's funny how, no disrespect to the plans, it's funny how once they have to start reporting something as a quality measure, that it gets their attention and things internally in the plan start to shift around and it becomes more of a priority to get that done. And if those initial screenings were really happening at the rate they should be, then how that flows into accurate diagnoses and care and support. I mean, it really could be a game changer. So I just want to applaud Anna and her team and what they're doing. And I know DHCS isn't here with us today, but there's some real champions within them, within DHCS, and they've been great partners with my organization. And it's slow, but we are moving in the direction, I think, of better care.
Thank you, Barbara, for your comment. Catherine, you're next.
Thank you. Great and very informative presentations. Thanks so much. We heard earlier today about the important work that's being done with community health workers and promotoriats. And while I think they might not be doing the assessment, I guess I'm curious whether there's linkages between using them sort of as an outreach tool and a mechanism to get into communities that might be less familiar with the resources, and wondered if any of you could speak to that.
Yeah, I think there's huge potential. I don't think we have any partners where that's exactly their model, right? That I'm aware of, and it may be happening somewhere else in California. So that's not a super informative answer, but there's a lot of models that lean very heavily on community health workers for dementia. So there's the aging brain care model in Indiana that essentially trained up community health workers peers, really peer level, like middle-aged and older people, to work with people with dementia and help guide care partners very specifically around behavioral symptoms and depression and dementia. And I mean, a really brilliant model, because it's like the right people to be supporting people with dementia. And it's the right emphasis if you want to really improve quality of life and reduce, acute care use. The other thing that makes me think of is Wisconsin, I believe, has a model where they are screening in the community setting. So I don't know if it's with community health workers, but like frontline community service specialists do the screening and then communicate to primary care or other medical settings, like what they've learned, to help be part of the team as they already are, right, and caring for people. And then I think a little bit about our own ECM teams that use health workers really heavily to, in the CalAIM work that they're doing to, get stuff done and support people and be navigators for them in the community. So it seems like I'm sorry, I missed that presentation. Seems like a very viable model, and a very resource savvy model to support, because honestly, from a primary care clinic, from a four walls approach to advising people on dementia and helping them really get, resources, skills, education, connections, we're terrible from an office setting doing that. It's just the wrong place to be doing that. And then most providers, I have no idea. Many providers don't actually have experience caring for somebody with dementia, or many do, of course, it's extremely common, but I think some people just don't really know if it's all on the healthcare team or a healthcare provider. I think social workers are obviously really valuable. We don't even really have a robust social work system where we are. I don't think all primary care clinics do. But providers or the medical side of things don't really always have those skills, and the community health workers really do. So I I would really think that would be an important avenue and potentially very fruitful.
Okay, thanks for that. Appreciate it.
Anyone else who would like to make any comments or questions? Well, hearing none, I'd like to thank Dr. Chodos and then Danielle and also Clara for attending this meeting and give us an overview and some updates about the Dementia Care Aware. I'm very impressed by the slide deck that you put together, especially the call to action. So again, just to remind everyone, we need to learn, to engage, to share, and to give, so that our whole state will know more about this very important venture. So having said that, I would like to conclude the discussion about this topic. I would like to give it back to Catherine, who will lead the next discussion to finalize recommendations and items for Secretary Galley. Over to you.
Great presentations today. Just really appreciate all the wonderful information. We're at the point in our agenda where we're going to talk about some recommendations to the secretary. As you're thinking about that, I'd also like you to just think about the 3 opportunities we have for committee engagement before our next meeting. We will be doing a presentation in May 2023 about decision-making capacity and supported decision-making, which came out of a piece of legislation last year as another way to support people in making decisions. If you're interested in helping frame what that panel presentation looks like, just drop your name in the chat and Michelle will pick it up, or separately email her, and we'll be setting up some time for a small group to get together to plan that presentation. And then there's a national plan to address Alzheimer's, which has recently been released, and we are looking for a subgroup to put together a presentation about that. And so if you're interested in working on and looking at the national strategy to support family caregivers, again, put your name in the chat or separately talk to Michelle and we can include you in that part of the presentation. One of the things that I really like about this committee is people's engagement in helping plan presentations that are of topics of interest that were sort of identified at prior meetings. And we've been working our way through all of those topics. And then last is Derek, in his remarks this morning, indicated that there's the long-term services and supports committees that's looking at ways to address social isolation and other care issues that were sort of brought to the forefront in the pandemic. Derek is our primary liaison to that committee. Thank you for doing that, Derek, but we need a second person. So if you're interested in participating in that, please also let Michelle know or drop it in chat and we can kind of get the right people in the right place to continue the good work we're doing in between our quarterly meetings. So you heard Dr. Galley say he would specifically welcome our advice about the community health worker promotores that we've heard a lot of presentation about. So that's one topic. And then several items came up in the legislative platform, including the composition of this committee, if we want to give any advice about that. We also heard in the legislative presentation, as well as in this, sort of the progress in Dementia Care Aware and what may need to happen long-term and connections between that and the other research, dementia research centers. So just opening it up for any of those topics, as well as others that you might want to have included in the list of items that we send as a report to the secretary after each meeting. And thanks in advance to Michelle and Julie who help put that list together. So I'll open it up for people's ideas. Derek.
Yeah, I'd like to kind of talk more about the idea of having Office of Brain Health. I think it's very important, not only in the sense of preventing, any deterioration in dementia, but also in terms of the general health of individuals. So say, for example, we are all asked to have an annual physical checkup. So we might have blood work and that kind of stuff to determine we have high cholesterol or hypertension or high sugar, right? So, but imagine, there's like this graphic which UCSF put together is revving the engine. So imagine our brain is the main engine of the body. So it makes sense to me that we should have a regular brain scan so that we know exactly what's going on and we can have a lot of idea how to prevent things from getting worse. So that's my plea to this group, is to see if we can, talk to Dr. Galley and have this put into consideration.
Thanks for the comment, Derek, and the good thinking that you've brought to the importance of brain health and people being aware of, any underlying conditions and so forth. So thanks for that. Other comments, Dr. Mobley?
Well, just to respond to Derek, I think I might reframe the thought as follows. What data do we have? What rigorous evidence-based data do we have that teaches us what is useful in terms of predicting and responding to changes in cognition with aging? It may be, for example, the brain scan is not very sensitive. In fact, in the very early stages of dementia or preceding dementia, there can be changes in blood biomarkers that might be much more informative than brain scans. So I think it's really, and Anna and Clara and others, part of the Dementia Care Aware, I think that's a good place for that discussion to happen, because ultimately guidelines that will sort of support PCPs might well include a rich sort of discussion around what biomarkers, what other measures might be used to predict the onset of Alzheimer's disease or other dementias, or in the early stages, what additional tests might be used to characterize the extent of the damage. So I think this is fundamentally a question for neurologists and for those who study the brain to kind of come up with a really a rich set of very informative biomarkers.
Thanks for that. And I think Derek was talking, kind of in the way you were, of thinking about what represents good brain health and how we might assess that, but thinking that that should be part of the things that are looked at during a person's annual physical exam as a way of identifying, helping identify early signs of dementia or other brain challenges, right? So I think that's a good addition. So thank you for that. Others have comments that they want to raise with Dr. Galley. Andrea, I think you when he was speaking, you talked about the importance, I think, of ensuring that as we think about community health workers, that we think about organizations that may be smaller but very well connected to local communities, and the strength that those organizations can bring to providing information, being a referral, identifying places that people can be referred. So if I'm summarizing that correctly, I just want to make sure that that gets added to the list of things that we include in the formal report. So feel free to add other to that.
Yes. And not only that, what are the barriers that keep small organizations from tapping into the resources and the funding source? Because we assume that underserved communities are getting these funds, but if there's a barrier from them getting these funds, then the work is not being done. And it may help us understand why for years that they're still not being funded through our communities. I mean, there's just not a lot of funds in our communities, and it could be because there's a barrier in a more upper level. between, federal and state, or the organization that's getting the funds, and then the people that's trying to tap into their resources, they're not able to, maybe they're not qualified, I don't know, but there's definitely a disconnect because it's not trickling down to the communities that need it.
Okay, thank you for that. And I think there's wisdom in that when we're thinking about the community health worker projects of keeping the qualifications such that individuals from diverse communities can be identified as Medicaid providers of community health services. And I think that's one of the challenges that James and others are trying to figure out. How do you do that? So appreciate
and just one other point. And so that really helped people understand systemic issues, because if there's barriers within the system, then the funds are not getting into the community. And this is a systemic issue. It's big. It's really big. So and it only makes sense for them to partner together to make sure the work gets out there to underserved community. And I'm talking all underserved communities.
Okay,
thank you, Catherine.
Thank you. Pam, I know earlier you mentioned the importance of the training of physicians for early diagnosis and treatment. And we just finished that great presentation about Dementia Care Aware. I didn't know if you had any comments or hope having heard that presentation about what the future might tell, but really interested in your perspective to add to the report.
Yeah. I think that one thing that came to mind, and I don't even know if it's appropriate, is when I started going through, feeling out like I had something going on, and my husband and I kind of figured something was going on, I made the mistake of going to the doctors by myself. And I don't think we've talked about that at all. And I was trying to figure out a way to kind of, talk about that a little bit. And I already mentioned earlier that, I went to my primary care and he said, you don't look like you have Alzheimer's. Thankfully, he did refer me to a neurologist. And I did go to the neurologist. And again, I went alone. And I think that there's got to be, I kind of wanted to jump in and talk about the paperwork, or, does it say in whatever's written down that make sure you have somebody with you, make sure you have a companion with you, make sure you have somebody that knows you, not just somebody driving with you. Because my husband was the one that was like, well, wait a minute, this is, there's more that's going on with this, because I can't, I wasn't articulating what I needed to say. So that was one of the things that popped into my mind. And the other thing is, I'm just really curious about UCSF, and because that's my hospital and that's where I got my diagnosis, and that's how I've had all my, I've had 2 clinical trials there. And, I would like to be more involved in some of that, but I don't really know how to. And I don't have the ability to get there by myself and all that other kind of stuff. So I was listening and trying to figure out what made sense, for me, or for me to share what's going on with my story. And definitely things have changed in the last year, quite frankly. I mean, I know that I'm going downhill, but at the same time, I can still drive and I can still cook and I can, take care of myself. But I'm happy to be here. So I don't know if I answered your question, but there's just a lot of, ins and outs of this whole thing that's kind of frustrating at times.
Yeah, so I think the point is here's what I heard, in some ways, how do we support people who are going through the process of getting an assessment and encourage the use of supporter? I'll just say the word supporter generally, and that could be a family member or someone else that knows you well, right? And that those kind of connections are important, particularly for all of us, when we're embarking on something stressful or unknown, etc. So I think we can find a way to include that in the report. So
Yeah, and I was
thanks for
wondering
that.
if, you know, they wanted to make that, like, they have to have somebody with them. You know, like they can't go to the doctor unless they have somebody that's with them, so that they can bounce back and, you know, bounce back and forth. Like I said, I don't remember what I did or didn't say. But once I got to the doctor, you know, and I got my diagnosis, then we knew, and then we kind of went down the path. But yeah, thanks for asking.
Yeah, perfect. Thanks for joining and participating. We have Barbara and then Sally.
I'm just wondering if we could include some language, keeping in mind the point that the Dementia Care Aware funding is ending soon. There's so much good work that this program has generated. I don't want to see it just disappear when that funding is gone. So I'd love the secretary to start thinking now about how to maintain and build on what Dementia Care Aware, their work. So I don't know if that's asking for funding to keep it going, or just thinking about how can you integrate their work into ongoing programs. But I just, some language around, you know, let's not lose.
So maybe it's like the work is important, and you know, the efforts that are advancing kind of the screening and assessment should be built upon and continued, something like that. And we don't yet know what form that would take, but I think worthy of a recommendation. So perfect. Thank you, Barbara. Sally.
Yes, speaking to Pam, and perhaps because I'm an attorney, I have a little different approach or thoughts about it. As far as bringing somebody into the physician, there is always the concern, and I have seen it happen, where that may be a family member who is trying for that physician to say, hey, mom is incapacitated, because they're trying to exert undue influence over them. So just as I, as an attorney, it is extremely critical. Many times those older adults come to me by their children. It's critical that I tell them I must meet with that older adult alone. I have to be satisfied that they have mental capacity and what they're doing is of their own volition. And, you know, particularly when it was the Dr. Chodos who was saying the number of primary care physicians don't understand or appreciate who does and doesn't have capacity. That number is pretty frightening. So I think it's, I understand, I think it is important to have at any critical life medical event to have some family member or good friend to come with you to the physician appointments. I know when my dad got sick and my mom got sick, I attended every single appointment with them because they can't think very clearly at those times. So they need somebody. So I'm just saying, at least the first visit, the doctor has to make that assessment on his own.
Yeah, I think that, you know, like, so we all agree support's important, and we also all agree that we don't want people taken advantage of, and that maybe a component of the training is sort of helping physicians that might be doing this assessment or talking with someone understand when the person is able to think for themselves, and when one should be, what are some red flags for a time when maybe there should be a separate conversation so that you could do an assessment without a supporter being there. So complicated issues that I think will come up, and thank you for volunteering for our presentation next month on consent and capacity. So it'd be great. Thank you.
You're welcome.
Clara.
Yes, I just wanted to say I'm so appreciative and grateful to hear from all of you. And Pam, it was really great to hear your story. So thanks for sharing. I wanted to emphasize that the cognitive health assessment that Dementia Care Aware has developed, it's really looking for three main components. We're asking providers to do a cognitive screening, a functional screening, and then the third component is actually the patient support system. So that's kind of the three main components that are highlighted within the cognitive health assessment. And I think that really gets to all of your great points about how the patient support system is an incredibly key component that often gets missed. And that's why, again, we've developed this training. We're doing all this great work to try to advocate for it and spread it to all the different primary care providers. I just wanted to emphasize kind of what Barbara and Jared and others have brought up. We obviously did receive funding, but our funding has to be used by the end of March 2024. So we kind of see that as a very scary cliff that's coming down the pipe for us. So we would love all of your thoughts and input on how we can continue our efforts, because as you all can imagine, getting a statewide program together takes so much effort and time. I would hate to see that all go to waste. We've developed some really great momentum, and to continue with that car analogy, I feel like we're just now getting off of that starting line, and I would really like that to continue and not have to stop after just, you know, a mile into the road. So I definitely appreciate all of your guys' input and support. So thank you.
Terrific. Thanks for that. Other comments from committee members about what we want to include in the report? Okay, I'm not seeing any other hands, and I think we are now at another opportunity to hear from any members of the public that want to speak. So if we could ask the CDA folks to facilitate that, that would be great.
Perfect. So just reminding everyone, you can use the Q&A function to ask a question or select the raise hand icon. And we will unmute your line. If you're joining by phone, you can press *9 on your dial pad and raise your hand, and we'll call out the last 4 digits of your phone number. I'm seeing one hand raised currently for Janet Van Zoren. Janet, I've unmuted your line and just get you to unmute yourself as well and go ahead.
Hello. I just wanted to comment on the Dementia Care Aware program. It sounds like they're doing wonderful work, and I'm so pleased to see that that's being done for the for the general population. I hope that they will continue, and I hope that if it does continue, that they take on also addressing the needs of those people who already have cognitive deficits and also need assessment for dementia. And all the wonderful things that the program is doing for everyone else needs to be done for people with Down syndrome and for those with IDD who also develop dementia. So I just need to put the plug in for that. Also, another comment, I forgot now who made the comment about the diagnosis and checking for other things when someone is thought to have Alzheimer's or that type of dementia. My daughter has had experience with dementia and was at one point diagnosed by a neurologist as having Alzheimer's. We were told that she had Alzheimer's because she had Downs. We didn't think she had Alzheimer's. We knew that she had Downs. Her symptoms didn't match. So we kept pursuing what was going on. And it turned out that she had a metabolic dementia, a type of dementia that causes metabolic abnormalities that resulted in dementia. And that type of dementia can be diminished enormously through medication. It turns out that she has Addison's disease, which means that her adrenal glands were not producing enough cortisol. And now that she's on treatment for cortisol, she's recovering from dementia. Whether or not she'll ever regain the competencies that she once had is still questionable, but the improvement has been very remarkable. So it's very important that when someone is diagnosed with Alzheimer's, that other types of dementia are ruled out. Thank you.
Thanks for your comment. Are there any other comments from members of the public?
Not currently seeing any other hands raised, Catherine.
Thank you. Thanks for letting us know. Any last words from members of the committee? I don't think we have any last words either. So thank you for joining today. I think our next meeting is maybe May 4th, if I'm remembering correctly. Thanks to the staff for getting all of those set up and sending us appointments about those. So again, it'll be on Zoom from 10 until 2 with a little lunch break. And as you can tell, we'll have some presentations that are helped framed by members of the committee. So we look forward to that work as well. Thanks so much, everyone. Have a great February.
Thank you. Bye-bye.
Bye.
Thank you.